You can. All right, well, I'm going to go ahead and get started so we can jump into our first discussion here. Hello, everyone who's joining us. Welcome to our second annual Washington ACC Cardiovascular Team Symposium. My name is Katie Bates. I'm a nurse practitioner at Confluence Cardiology here in Wenatchee and your Washington ACC CVT representative. Thank you so much for joining us on your Saturday. We've got a great lineup of topics this year from speakers around the state. I'm especially excited for our panel on telemedicine with our Congresswoman, Dr. Kim Schreier, at the end of our event, so make sure and stay tuned for that. Each of our talks today will be about 20 to 30 minutes with a Q&A following, so please engage with us by putting your questions in the question box. It's called Q&A, usually at the top of your screen. And you can also use the chat function to communicate with me or other attendees. And I'd also love if you could share with us who you are and where you're joining from today. It's always great to see all the different cities and places that people are joining from. As with any virtual event, there might be technical issues from time to time, so please bear with us. If we have any delays in speakers, feel free to engage in that chat function, as I mentioned. Thank you again for being here on your Saturday. As your CVT representative, I've been pretty painfully aware of the difficulties in meeting and connecting with all of you over the last year and a half or so, and the Zoom fatigue has been real for all of us, so I really appreciate you logging in today to spend some time with us and learning about these great topics. So without further ado, I would like to introduce our first speaker. Jennifer Bain is a licensed social worker with Tacoma General Heart Failure Clinic with a passion for addressing social determinants of health in the care of cardiovascular patients. This is something I think we all encounter and struggle with on a daily basis. How do we provide the best care for our patients who are attempting to manage very difficult diseases like heart failure, but also battling things like addiction and homelessness and other significant challenges. So Jennifer, welcome, and I'll hand it off to you.
Thank you. I'm just working on getting my screen shared. All right, does it look all right?
It's great.
Righty, just making sure everybody can see anything and let me know if I do anything to mute myself unintentionally. So thank you again, really appreciate anyone's interest in this at all. As a social worker, this is a topic near and dear to our hearts and our education, and just appreciate to be included. Yes, I work for, actually I work for Multi-Care Health Systems through Tacoma General, through Pulse Heart Failure Services in Tacoma at their Tacoma clinic in the outpatient, and I kind of help bridge the inpatient flow to the outpatient follow-up. And then, as you know, especially in heart failure, we typically have these patients from diagnosis to death. So we have a very long relationship with them, and I've learned quite a bit in the last 7-8 years doing this job. Yes, also to say I have no disclosures. So moving right along. Feel free to email me or pop up with any questions as they in the chat, and I'll try to answer them afterwards. Okay, so what are the social determinants of health? CDC has a nice definition. It's the conditions where people live, learn, and work, and they affect a variety of health risks and outcomes affected by power, wealth distribution, and the availability is key of global, national, and local resources. The determinants elucidate the unfair and avoidable differences in health status, and they're mostly responsible for health inequities. So I'm going to view the outcomes for both patient and providers through a couple of HEDIS and HCAP measures through that lens, and we're going to discuss how attentive care to the social determinant factors can make a really huge impact for both patient and the provider. As you know, the measures are watched closely. They affect reimbursement, provider ratings, bonus structures, pay increases for all staff system-wide. They're also closely tied to our own and our own health system's response to their patients' social determinants. So we're here looking at a key word here is avoidable. That is the first outcome we can contribute to positively by attending to, or at least at a minimum, recognizing the social determinants of the individual that our services are prescribing and caring for. One of 2021's HEDIS measures is statin adherence. You can see that there on the bottom left. Medication non-adherence could be impacted greatly if we knew why they were not making that 80% marker. This is their finances, food over medication competition, high copays, no Part D, inability at all to acquire health coverage. Once we know these factors, we can actually refer. We need to have those structures in place, or at least some staff in place for that. But having some basic knowledge, we can do a lot of this just individually ourselves. The key thing is to identify. So if you're wondering, the 80% adherence to statin HEDIS measure, it's determined by the member being prescribed and remaining on their high intensity or moderate statin medications for 80% of their treatment period. Basically, how they capture this information is the pharmaceutical companies, medication assistance, and reimbursement companies measure, or the insurance companies, the insurance companies see how often their prescriptions are filled, and then they can get a measure of the members' adherence. If they're not filling it, something's wrong. So let's ask what those factors are, why they're not filling it and hearing it, so that perhaps the practice can prescribe an alternative. Less effective medication is better than no medication. Something that we can help them with our pharmaceutical company medication assistance applications and whatnot. And again, remembering this is an avoidable factor, one that we can mitigate if we have the staff and time and the know-how. So the social determinants of health wheel, this is a very handy little tool. It helps you just kind of get an idea of the 10 domains: financial resource strains, transportation needs or lack thereof, alcohol and substance use, depression, intimate partner violence, social connectiveness, physical activity, tobacco use, stress, and food insecurity. How these questions and these graphs are usually things that you through Epic. They are available through Epic, but they are an add-on feature, so your system would have to add it on. We are currently at Multicare. We are starting to gather this data through our ambulatory clinics and anyone else who is able to enter it through their flow sheets. That usually flows right into the social determinants health wheel that we can watch over time. So how we ask these questions are basically as part of your H&P. Do you have access to transportation? Do you struggle to make ends meet? How often do you talk with your friends or family members? The Epic information makes it much easier to see, document on, and track over time. And clinicians can also assign these questions their patients through a MyChart portal if that's available. And then whenever you hover over each cursor, over each domain, care members from across the system can see the relevant patient responses, changes over time, regression, and hopefully progression. So I really think of this wheel as a great visual tool when I consider how it can change over time with really solid patient-provider relationships that are positive, especially for patients who perhaps when you first met them 5 years ago, or even just 6 months ago in the ICU, were a complete, HFrEF exacerbation, but they received excellent attention to their social determinant issues, provider-initiated social worker resource referral. Maybe your outpatient clinic has an amazing nurse navigator who can work with those high barrier patients on knocking these barriers down. And then suddenly half of these factors are eliminated sometime later. But it does take time and a little bit of work, but it is not impossible. Again, most of these factors are avoidable. The outcomes, and again, outcomes for provider and patient, they're truly priceless to see that improvement and the rapport that can develop. So how do these issues impact our patients? Essentially, whenever the cost of healthcare competes with the cost of the basic needs, food, housing, other essentials. here are the common ones: money, fear and distrust, health literacy, food deserts or inability to access simple things like transportation, ability and disability differences. Cultural normatives are a huge influence. They can be challenging, but they can actually be utilized to help move patients toward adherence to the plan. And also the inability to access advanced therapies. So fear and distrust, avoidance of care, even negligent care, it can be due to a lot of factors. There's a historical, there are the historical negative experiences of African Americans and other minority groups who underwent covert testing, research for medical advancements, but these were born on the bodies of people who did not give consent, and the echoes of this legacy still exist. It created a lot of mistrust in the healthcare system for a lot of different populations. Concerning health literacy, research shows that patients remember half and understand less than half of what clinicians explain to them. So that E and AID it is extremely helpful. The explanation that we're giving needs to be relevant to the patient and in a manner that they can understand. Also conveyed in a way that they trust what you're saying. So if a person who has general or low, or who has low general health or low general or health literacy, think of how much less that they might actually understand what's being explained to them, and it may need to be done multiple times. A food desert is an area that has limited access to affordable, nutritious foods, in contrast with an area with higher access to supermarkets, farmers markets, et cetera. Those are called a food oasis. Food insecurity in Washington state is a most definite social determinant factor with a high likelihood of elimination through effective referrals for social determinants. We have federal supplemental, the SNAP program, the Supplemental Nutritional Assistance Program. It has a fairly attainable eligibility. We have very good food banks, especially in urban and suburban areas. Pierce County is blessed with for example, specialty food bank for liquid nutrition by provider prescription. So we are quite lucky here in Pierce, and of course in more rural areas that might be more difficult. Seattle might have even more. It just depends on where we are and where our patients live. Cultural normatives, who's really in charge? Obviously the patient is by our laws, and we know this, but paying attention to their particulars of their family dynamics and what's normal for their culture or typical would be something that really inspires confidence in you as a provider or staff member in healthcare from these patients. Respecting the culture of how families with patient consent make decisions will assure that the right persons are involved in the care plans. So an example of this might be how some Polynesian cultures make major decisions with or through their family's high chief, who can direct money and other resources to families in need from the other family units in their who the chief has oversight of. For homes of patients who have substance use disorder or history of instability, poor social support, it means some of these patients can't access advanced therapies. So it's not equal across the board. There are circumstances, if we can mitigate them, they would be accessed, but it's more complex than that. Some of the things that are not able to access are home inotropes. The infusion companies won't go to homes that are unstable, mechanical circulatory support, LVADs. They're not able to receive that without good social support at home from their family. So I think with consideration of these factors, when there is an attempt to even ask and evaluate, their social determinants can be mitigated more effectively through these more appropriate referrals, recognition, conveyance of interest in their personal life situations that contribute to their poor outcomes. And once patients come to the realization that they're receiving attention to these factors, and they may not have experienced in other provider visits, their confidence truly grows. And this really leads into higher patient satisfaction, which is what we're going to talk about next. And that's an HCAP measure that we're looking at. So patient satisfaction, everyone's favorite HCAP measure. Patients who are satisfied with their physicians are more likely to adhere to their medications, which will ultimately lead to greater disease clearance and lower healthcare costs. In order to increase the patient satisfaction, it's beneficial to optimize the doctor or provider-patient relationship. Improving aspects of communication can dramatically strengthen this relationship. So the Hospital Consumer Assessment of Health Care Providers and Systems, HCAHPS, it's administered randomly to samples of adults across multiple medical conditions between 48 hours and 6 weeks after discharge. Started in 2002 when CMS and Agency for Healthcare Research and Quality partnered. They did the research and they were cleared for use in 2005. So just in those few years since then, since about 7 years after they initiated the research, they've actually found that when patients feel they are not heard and their circumstances are not considered, their adherence and investment in their medical plan drops. No-shows increase, reimbursement decreases, medication and plan non-adherence occurs. If you can flip it around, something else happens. We get the opposite. We get adherence, we get rapport, we get better questions, and we have a stronger patient relationship. So as you can imagine, there's the top 5 of our responses of from patient satisfaction responses that their complaints. Here's your top 5. A nice visual representation. This is from a 2021 article, and they gave a review from their surveys. What is number 1 by a super clear margin, almost twice? It's communication. Showing interest in their factors, it will cultivate a sense of care by the individual, and it does start to convey empathy from the provider, which is really important. So has anyone heard of this study by this professor? It's Maribarian. I think it's 1982. The communication factors, he had this lovely communication model, the 738-55 communication model. Essentially 7% of message pertaining to feelings and attitude is in the actual words that are spoken. 38% of message pertaining to feelings and attitudes is paralinguistic. It's the way that the words are spoken. But this one is interesting. 55% of message pertaining to feelings and attitude is in facial expression and body language alone. That's interesting. This involves 0 words at all. So the most influential factor can be conveyed through facial expression and body posture, eye contact, appropriate physical contact during physical exams. Patients know when you're rushed by time and the time that is spent that's examining their areas of complaint. At the very best, this can translate as indifference. At the very, very worst, it's an assumption of deception or poor skill. That's the worst. What we want them to know is that we are paying attention to them, and they will pick up on this. So I think it's important that we make better eye contact, adhere, ask more personal questions. So once you identify these, what do we do with them? Again, it's going to be very, very heavily dependent on what your system or your individual practice can offer. We've mentioned social work or referrals in the hospital, or if you have one through your practice, or a resource referral through your hospital or your practice. If you don't have that, any kind of development of a strong nurse or social work navigator program in an outpatient clinic really can help bridge inpatient to outpatient, affect those 30-day readmissions by getting them reduced, by having that special attention to these folks' needs. There is a push for more simplified web-based resource hubs. Here's an example of a community-based resource tool that is free. One of it's through findhelp.org. You enter the zip code and multiple things pop up there. I think there are about 15 things that I was able to find for this one zip code. Other examples are a program that was called Aunt Bertha. And then most Washington counties and areas have the 211. You dial it 211 to United Way in order to help for resources and other things in your community. And those are very current, those, especially 211, they're very up to date. Multicare is looking into investing in a program called Unite Us. This is a little bit more in depth, and it is at a cost to the system. So it's something that you would purchase or add. One of those nice things that the paid platforms have, it has data collection, follow-up, it tracks the outcomes, identifies service gaps and for at-risk populations. And it proposes empowerment to the members of your community to help patients take ownership of their own health. Now, I'm not a really pessimistic person. I'm just a worst case scenario planner. But what if they can't, knowing the difference between can't and won't? What if they can't do these things for themselves? There's a difference between cannot and will not. And that's a determination that our providers can really help the other staff and support staff, social workers understand. I don't think they can do this, or versus I don't think they won't do this. We deal with a lot of cognitive disruption, as you can imagine, in heart failure, a lot of low output, low ejection fraction. It's a major problem for our really poorly perfused patients. Cognating is very difficult just for day-to-day items, and there's a lot of confusion. So identifying these patients through can't versus won't, we can assist them according to ability and our bandwidth and staffing, especially now during COVID. Refer them to direct assistance, meaning sit down with somebody, have them help them with the actual paperwork, tell them where to sign, show them how to do it. If that's not available, consider how to modify your practice to fund staff for resource and health system navigation. Advocate for health system foundation or charity funds. Help with fundraising. That's a big deal. Providers are, and physicians especially, are incredibly influential, so anything would be wonderful. Social work discipline, there's a saying, we should not work more, do more for the patient or client than what they can do for themselves. This is not because we're callous. It's that the individual can reap the rewards of that self-advocacy engagement. So think about this for the substance use patient seeking treatment. They don't do the work, but they don't reap the rewards of the confidence, personal agency, and pride that comes with doing all that they can. And there's no growth. And keeping patients engaged in their care planning is essential. If there's no buy-in, there's no adherence, and that's more frustration for everyone. In my clinic, my outpatient heart failure clinic, we have a very high barriered community with no shortage of heart failure patients. After 8 years in medical social work, and I did 15 years as a paramedic before that, I feel really confident my team and I can identify the can'ts over the won't patients, free of bias. Really, it's about function and ability. We do the forms, upload them to the websites, we find the copay cards, contact the pharmaceutical companies, negotiate foundation funds dependent on availability. Some of the more interesting things we've advocated for: an Amtrak ticket for an LVAD patient so he can get to his new caregiver after the old one could not help him anymore. Lots of DME, safety equipment. We got a portable generator for a gentleman whose trailer caught fire last year, and he is in the middle of January, so we really needed to help that. We've also developed a plan within our health systems pharmacies for limited prescription assistance. When you have patients in the Medicare donut hole, or someone who does not have a legally present status and is ineligible for health insurance or medications, not being able to work for 3 months after something like this is a recipe for occluding stents and other revascularized vessels. So the more we can do, the better, and it helps their outcomes, and our outcomes obviously are benefiting from that. So how can you help with a positive impact? Learn about what's available. You have a lot of pharmacy reps like we do, I'm sure. Talk to them, get their input, say, how do we make this easier for these patients? Make them tell you how, and they will, which is really great. Know the patient's barriers, prescribe affordable alternatives to the or underinsured. Don't start meds if they can't complete the med or sustain the med without consideration of their factors, especially for those high risk and high cost meds. Educate our patients about what your resource staff can help them with, and have them follow up. So for example, I put a couple of these copay cards up for Eliquis and Entresto. Sorry, that got cut off on the bottom there. But just having a general idea of who's eligible for these and how they work is really, really important. I think our acute care NPs probably carry some of these around in their pockets, or if not their office, when they're discharging patients, to just kind of show them and get them at least initiated. And they know what those eligibility are, what these eligibility are. If they're Medicare, TRICARE, other federally funded, they're not eligible for the $10 copay, but they definitely can get the 30-day free. So, but making sure that that's still the case and staying current is really, really important. Oh, actually, one of the examples I did throw up here was for, we want to get to GDMT, prescription for Bidil, great drug, had a lot of lovely research on it a few years ago, but the cost is insane, $343 out of pocket. It would be considered a high tier med for the Part D and Advantage programs, which means it's anywhere from $40 to $60 as a copay. Another alternative, it's not the best, and it maybe doesn't metabolize the same. Again, I'm a social worker, not a scientist or a pharmacist, but we have isosorbide dinitrate or isodil and hydralazine that we could throw down for significantly less. Also know your pharmacy prescription assistant areas, especially for those meds you prescribe the most. I have a few listed on here. We deal with these folks on the daily at our clinic, and we have very good relationships with them, so we're lucky. So if you have any interest in follow-up, please get to know the area that you're prescribing, where you're providing and prescribing any of those services. There's a lot of very interesting data out there just to get information. Here are some of the tools that you can use to help. We have some health literacy tools that you can use. I think a lot of people have heard of Realm. Get to know your system social workers. And if you go between the inpatient outpatient world and don't have one outpatient, grab your inpatient social worker and ask them, can we have a little FaceTime to talk about resources that are here? Can you help me out with me developing my own lists that's relevant to your own practice? Your care management staff and your hospital nurse navigators are amazing at every hospital. They would be some folks to get to know as well. And then be specific in your practice about what your navigator roles and their expectations, because not all navigators perform same duties. So they're not the same transferable. I know our AMI navigators their duties are very different from our heart failure navigators. And advocate for your system. You providers and physicians, executives, incredibly influential folks. If you have the ability to give to your own foundation out of your own pocket, bless you. I make a social worker wage, but I give as much as I can to foundation. I love our foundation. I have a really great foundation that really helps our patients a lot. So I feel good when I'm giving out those resources, and I'm advocating for rent or some other thing that we can help them with. That's essentially it. We only had about 15, 20 minutes. I think I went a smidge over. I really appreciate everyone's attention. If you ever want to connect, collaborate, talk about the work, please contact me. I really enjoy talking about this a lot, obviously. Do you have a little bit of suggested reading here? Really interesting articles on the Roma Gypsy population, racial microaggressions, supporting rather than punishing pregnant women with substance use. There's all kinds of these SDOH articles that when you get to know a little bit more about it, it's fantastic because we can make a huge impact. And my references, also have my reading list on there as well. So please, if in the future, any questions, please let me know. I'm very eager to talk to anybody about this. Thank you very much for your time.
Thank you so much, Jennifer. That was excellent. It's clear that you have a passion for this and you are in the right calling for you. So we greatly appreciate what you do for our patients and what all social workers do for our patients. It is not an easy job, ripe with frustrations as well. And, I think it was really important to note something you talked about in establishing rapport with patients by helping them meet their basic needs before kind of moving on to the let's get you on all these medicines and all these advanced therapies and all these appointments. When you think about, Maslow's hierarchy of needs and people at the core are just trying to survive. If they feel like you are there to assist them in some way to do that, then, it ultimately probably benefits you down the road when you try to say, okay, let's, work on your heart failure, your heart function. So I think that was a really important takeaway for me. I'm just looking to see if there's any additional questions from the audience or from our panelists before we move on to the next speaker.
Katie, can you hear me?
I can, yes. Is this Dr. Nayak?
Yeah, so Jennifer, that was an awesome talk. One question I have is kind of looking at Mehabarian's, impact in terms of body language and things. What are you seeing in terms of like telemedicine and where that impacts the social determinants of health, and how are you kind of getting around some of the barriers with telemedicine, especially since so many of our patients can't even get the video, component of it dialed in?
That is such an excellent question. There's little things that we can do. Just appearances are so important. people need to see us. People need to see that we care. So not having that one-to-one is we were just talking just before getting on this morning, can't wait to get back to in-person conferences. Look at how much more, I don't know, gratifying they develop that rapport. There's the ability to network, but there's so many things you get from in-person. But if you're sitting in a virtual visit and your provider is like this the entire time and there's no eye contact, where they're out of screen, can't hear them, it's a grand total of 5 minutes of interaction. What kind of value do you think the patient is getting from that? These are tiny tweaks that we can do that cost nothing, that improve so much. And so I definitely look at it like that. When we were at the height of the first surge, we did our darndest to have, I mean, we had lots of technology breakdowns in that first round. So we did them over the phone. We did the best that we could. We apologized. We said, hey, if we can get you in here, what would it take to get you in here? Because I don't like the way you sound. I hear you breathing. You sound tired. Now, this is just without visual. Remember, there's those patients that they look like they're part of the furniture. They're so exhausted. They're melted into the exam chair. We can't see that on a verbal or on a phone contact. So the impact is pretty major. So anything we can do to have a workaround or get them back to the actual hands-on or eyes-on physical exam is great. Then they have a little bit of social contact, get to establish rapport with everybody else in your service. And that helps so much. And the social support for the elderly right now, it's been horrible. We do as many supportive calls as we can. And we just talk. So that's part of our job. And at least the social work and our resources, our resource nurses, our navigators, they do their best to just connect with these folks. So by any means necessary, that's maybe the answer.
Thanks. That's super helpful. That's kind of been our experience as well. And, I just appreciate all of the work that you've been doing. And those slides were really helpful to kind of encapsulate so many things that we're seeing every day.
I'm going to send the slides over to Katie and Liana. So please, if anyone wants to look at it, the link should be active, the hyperlink, so that you can jump onto any of those readings, take a look at more closely at any of the other slides I might have had to rush through this. So thank you.
Great. Thank you, Jennifer. That was excellent. Excuse me. I'm going to move on to our next speaker, April Valdez, a nurse practitioner in heart failure, specifically an expert in heart failure at Inland Cardiology in Richland, Washington. Today, she's actually going to be talking to us about smoking cessation for our cardiac patients. And April, I'm excited for this talk as a refresher for me, and also just a deeper dive into how we can support our patients in quitting smoking. So I'll hand it over to you.
Hi there. Thank you for having me. Yes, I will not claim to be a complete expert in the tobacco treatment realm, but it is something that I've learned a lot about recently. And so I'm happy to share what I know with you. I recently got asked by our ancillary services, specifically our cardiac rehab, to provide essentially the prescriptions for a tobacco treatment program that they are partnering with the Tri-City Cancer Center. And so that's kind of how I got more closely involved. So let's just kind of cut to the chase here a little bit. Tobacco treatment plans look somewhat like this. We have to identify users and their willingness to change. We have to incorporate change talk into our meetings with them and our visits with them. And then we need to use combination therapy, which includes motivational interviewing / counseling. And I know that can be challenging for people. So it's something that we can learn more about as we get into this, but at the same token, can be really powerful when we're trying to help patients in the office. And then continued monitoring and interventions as we go along. And I'll share with you some more information about that. So I think we need to think about nicotine addictions maybe a little differently than we have in the past. Nicotine addiction is a chronic relapsing disorder using a repetitive behavior that they become very accustomed to. So what is in cigarettes? Well, I'm gonna try to minimize you guys so I can see my screen. Okay. 7,000 chemicals, 70 of those are carcinogenic. So this is really the problem with them. There's only one addictive substance, which is the nicotine, but really it's not the nicotine that's the big issue. It's really the carcinogens. So as we go along, it is helpful to know that there's about 10 to 12 milligrams of nicotine in each cigarette on average. So who is the smokers today? As we've noticed over time, since the 60s maybe, or even before that, our numbers are trending down with smokers. This is based on data from 2017, so a little bit dated, but we are down to about 15% of the population, except for, if you look, there are, piggybacking on Jennifer's discussion, there is certain populations of patients, specifically with educational levels and socioeconomic status, and even some racial and ethnic groups that are much higher than the average. Obviously, when we direct this towards cardiac patients, tobacco users are at higher risk for heart attacks, and of course, if they continue to smoke, are at increased risk for additional heart attacks over time. So the special populations that we've already identified are educational level. The good thing about this is that if you look, the chart on the right does show that the numbers over time since the 1960s are trending down to a lower percent than what once was. But as you notice, people with less than a high school education or high school education are at the higher levels of use. What I found quite alarming, unfortunately, is that the current tobacco use among high school students is skyrocketing with the invention of electronic cigarettes and other sort of electronic technology devices. So unfortunately, if you think about this, we may start noticing in cardiology as the younger population ages, for some of us who have many years to continue working in cardiology, that we may see more patients than we were used to currently. So if you add in the 20% of e-cigarettes with the 8% of regular cigarettes among the other lower used items, we're looking at a large population of young people who are potentially going to be addicted to these substances. Unfortunately, we also look that there's really a co-use with other substances. So marijuana, alcohol, things like that, you're going to have multiple co-use. So that makes, honestly, the tobacco cessation even more challenging, which we'll discuss here. I thought this was unfortunate. The military has a high percentage of people who are using tobacco, especially the Marine Corps, which is really unfortunate. So I think that's something to be mindful of, that we may be seeing these people starting to use these substances at very young ages, obviously, and then continuing as they start to see us in the cardiology department. As you know, ischemic heart disease has a huge proportion of death in the United States, and obviously we can see that cigarette smoking is a contributing factor to this. And we also know that it doesn't just harm the heart. I thought this was just a useful kind of image to show you that, many different systems are affected by this. So it's not just a cardiovascular benefit to smoking cessation, it's really a whole body benefit. What's great about smoking cessation is that once you stop smoking, there's huge amounts of benefits within very short amounts of time, to include the cardiac system. So your heart rate decreases within 20 minutes, and that can be beneficial for a lot of patients, even me and my specialty with heart failure, that's benefit. Among others, within 1 year, the risk of ischemic heart disease definitely goes down by half. So we're seeing huge benefits if we can get them to stop. I thought this was a busy slide, but I don't know, even myself, all of the different sort of tobacco products. So I thought this was an interesting image to kind of show you that there's so many different forms of tobacco that people can be using. And even within certain racial and ethnic groups, they may use something more than others. The image in the bottom middle with the blue is like a hookah. which I had never really seen before. And then it is interesting to note the bottom right is a snus. That is actually the considered the safest form of nicotine because it has the least amount of chemicals and the lowest amount of nicotine, and then everything else in between. This is helpful in that they found that the younger population of people are really drawn to the flavored products, so things that taste like or smell like fruits and other things. So many large cities are actually restricting the use and banning these products within the United States, which hopefully is a helpful thing. Unfortunately, you can still get refills for these e-products that are still flavored. So the cartridges are not sold, but the refills can be flavored. So it's a little bit of a catch-22, but it may help the younger population avoid these sorts of products. The other thing that's actually being banned these days is a menthol. So in certain states, mostly the southern states, I'm told, are really high levels of menthol cigarette and tobacco products. So that's being phased out as well. So the need, obviously, all of these populations of people, there is definitely need for intervention, and 68% of smokers do report that they want to quit. So this is encouraging. So how do we get this discussion started? One of those methods is using the 5 A's of change, and that includes asking patients, have you considered quitting? Communicate with them the importance of how it's affecting their heart condition or their health conditions, asking and engaging with them on and how ready are they, so assessing them. And then, you know, I understand that many clinics are strained and don't have a lot of support levels. So at this point, if you've assessed them and they're willing to change, then at least providing them with some resources or other services where they can get in contact with people who can help them. Quitline is one of them. I'll show you that resource at the end. It has some limitations, obviously, like we've recently talked with Jennifer's. It's really not face-to-face. It's, you know, by phone or maybe by, you know, communication over the computer. So that can be a limiting factor. So if you have something better than that, I would definitely consider that. And then assisting them in a treatment plan. And that's what I'm hoping to provide you with information today, some pearls and tips on what does a treatment plan look like, and are you actually prescribing what's going to be most effective to the patient. So one way that we assess the dependence of tobacco, this is specifically cigarettes, so there is a questionnaire for cigarettes and then other tobacco products, is the Pegastrom test. It is a 6-question test, tells us how dependent they are on smoking. And if you don't go through the entire 6 questions, which isn't too much, really one of the key factors is how soon after waking up do you smoke your first cigarette. So if it's within 5 minutes, that is a significant dependence, and that can help direct you towards the treatment plan. So one question can get you really directed towards what level of treatment plan are you going to need to think about. The score goes from 0 to 10, so you can kind of see the levels there, which can be useful for you in the future. And then the little clock on the right-hand side does tell us specifically about nicotine replacement therapies, the dosing. So you can see if people are starting to smoke before 30 minutes, then you want to consider higher dosing therapy, and we'll get into that in a second. So pre-quit nicotine replacement and counseling. So this graph essentially shows you that we need to use combined therapy with medications and with essentially counseling or even follow-up visits within the clinic, if you want to call it that. And we really want to start the nicotine replacement therapy before they quit smoking, which is something that I think many of us may not have thought about. And it's definitely shown to have better outcomes long-term. In this study, it went up to 26 weeks. So as you can see, the percent of abstinence over time does, wane and does kind of reduce. Unfortunately, it's a challenging and addictive substance, so we aren't going to have, perfect success rates. But as you can see, with in-person visits and the pre-quit patch in this study, we saw higher rates after 26 weeks of abstinence. So the first step, let's help them set a quit date. That can be done in the office relatively quickly. Within 2 to 4 weeks is the time frame that you want to kind of hope that they can commit to. We can address other things like triggers for them, how they can avoid these triggers, what are their concerns with withdrawal, and we can help them to understand when that might be the most significant for them, which is essentially within the first 3 to 7 days. Unfortunately, I have spoken to a lot of patients who really do say they have cravings even up to a year later, but it's more manageable for sure. It's just something that they still continue to think about. And we can continue to support them through these times. So what I was thinking in my clinic is that, you know, sometimes we have urgent needs that need to be dealt with, as we've previously discussed, and that's fine. We do what's most urgent, but then maybe if they come in for a follow-up and their guideline-directed medical therapy is stable and their, you know, cardiovascular status is relatively stable, then maybe this is the office visit that we can incorporate some education and assistance with their addictive substances. And that's just generally used by motivational interviewing. It's a term that's used a lot. It actually can be very useful, and unfortunately it takes a little bit of skill and learning and how to kind of really help the patient help themselves. So first line therapy medications include nicotine replacement agonists, antagonists, and partial agonists. So these are our first line, which includes the nicotine replacements, the bupropion, and the varenicline, which is Chantix. The second line therapies, as you see on this chart, are also available. Nortriptyline and clonidine, although less commonly used. What we want to help direct you towards in this discussion is combination therapy is the most effective. And I feel like that really works similar to what I do in heart failure therapy. It's a combination. It's not just a one thing, it's really a combination. So we really start with nicotine replacement because this helps the patient with the withdrawal symptoms and the cravings, which is really the biggest reason why people are most reluctant to quit. Many different forms are available: lozenges, nasal sprays, gums, patches, inhalers. The most commonly used are gums and lozenges and patches. So nasal sprays and inhalers are less commonly used, at least in my experience, but can be very effective in some of the studies. So use what is most appropriate for the patient. Unfortunately, people don't prefer to squirt stuff up their nose, I guess, to get the nicotine, although it is actually a really good way to get the nicotine within the system very quickly, and you'll see that in one of my slides upcoming. What I think that I didn't do well was educate them on how much of these products they're going to have to use. So within the first 6 weeks, they need to use, say, like the lozenge at 4 milligrams every 1 to 2 hours. So this is something that they're going to be like really using quite a bit of these products. So you have to prescribe enough in order to get them through the first 4 to 6 weeks. This is a quick little image if you want to, you know, print it out so that you can easily refer back to it, just essentially showing you the doses of each of the products. And this is an image there on the right that just shows you the nicotine nasal spray. You can kind of define the patient in 2 levels: light smoker, heavy smoker. Anything greater than 10 cigarettes would be considered a heavy smoker. In my education, it's mostly been said that really starting at the higher level of these nicotine replacement therapies, for this example, it's a patch at 21 milligrams. Even if the patient is, you know, right about 10 cigarettes or slightly below that, we can always start with the highest dose. It's really not going to give them too high of a dose, and I'll show you that as we go along. Helping the patient understand where to use these patches, of course, in the midsection, the torso, the arms, not preferred, of course, on the lower extremities, and making sure they get good adhesion. And they say not to use them in the same area or at least 1 week after. So rotation, different spots. They can even shower with them, it's fine. So general precautions for nicotine replacement is for the patch is to avoid these in certain populations. It's kind of a loose kind of precaution as far as what I know is that we would want to avoid this in patients with recent myocardial infarction, serious arrhythmias, or unstable angina. The thought being, though, is if they've been in the hospital for a heart attack recently and they've quit smoking for the last few days, then we want to really support them through that. So I think we have to take it case by case, and I think that might be the optimal time to start them on something that can help them remain abstinent instead of restarting once they leave the hospital. So that's why I say it's kind of a loose precaution. Bupropion is one of our commonly used medications, and this helps you to understand the initial dosing, that we start at a lower dose for the first 3 to 7 days, and then we increase the dose after that. What I think that is really valuable is that the studies support using this medication for the first 12 weeks to help them quit. And if they do quit, actually prescribing for an additional 12 weeks. So again, I think this is what we don't do in practice, is actually provide the adequate therapy. So remember that this is a long-term medication, essentially around 24 weeks. If you have somebody with abnormal liver enzymes, you want to be careful with this medication. And there is common side effects such as insomnia, dry mouth, tremors, and decreased appetite. So just educating the patient so that they kind of understand what may happen. Varenicline is definitely a commonly used medication. There's been some issues with cost of this medication, and there's been some issues with a recall. Apparently it was with the starter pack, so where you prescribed the starter pack, which gave you the doses listed on the chart here. Essentially, it can still be prescribed, but you may have to do a little bit more work in giving more instructions with this phase-in therapy. So it has been proven to be the most effective as a single agent for tobacco cessation. That's important to remember. It doesn't have to be used as a single agent. Again, I would promote combination therapy. And then there's ways to start this medication that can help the patient. And I don't think that I gave good enough education in the past about this, that we actually want to start the medication a week before they decide to quit smoking. We can also encourage the patient before they start this medication to kind of gradually reduce the cigarettes day by day until they're kind of down to what they feel is probably their lowest tolerance. So for everybody, that's different. And then there's other options there to reduce the use and then set a quit date and a little bit more flexible pattern. So I think that's something that is kind of a take-home message, is that the patient doesn't have to have quit smoking completely and then doing these medications. It's really melding these two things together. Patient education is listed here just for your use and tools. We want to make sure that they have an adequate creatinine clearance, and if they have a creatinine clearance below 30, you probably don't want to use this medication. But do make sure they're taking it with meals. Nausea and vomiting is a common side effect. And of course, insomnia can be definitely a problem. There is all of that information about the abnormal dreams and sleep disturbance. So it's something that you might want to caution the patient on. And of course, avoid if they're having suicidal ideations or significant mood changes. We're going to have to avoid this medication. There are many minor side effects that can happen with many of these products, whether it's the patches or the oral medications. And I thought this was just a useful tool to help the patient if they're having issues such as nausea with the Chantix. Are you taking this medication with food? Or maybe they're using the patch and they seem to be having some issues with sleep. So that can cause insomnia at night. So then they recommend taking the patch off at night. although some patients find it more valuable to continue to wear the patch 24 hours a day, despite what some of the instructions say, and that's fine to do. So there's a large trial called the Eagles trial that is showing that the efficacy of Chantix, bupropion, and the nicotine patch. So this is very interesting. It was a study of 8,000 people, so a really large amount. And it's giving you really how successful people were in continuous abstinence over a 24-week period. As you can see, non-psychiatric patients, people who don't have other psychiatric conditions, anxiety, depression, amongst others, they have a higher quit rate. So we know that psychiatric conditions definitely increase the risk of smoking, but also increase the difficulty in quitting smoking. So pay attention to these details when you're working with patients. Understand that we're seeing that the Chantix, Varenicline is the highest rate of abstinence over 24-week period. So this is an interesting graph that I really wanted to make sure that you guys saw. It's really the venous concentrations of nicotine with the various products. So as we see, the nicotine concentration shoots up within about 5 minutes when you smoke a cigarette. That's the top line in the blue. And so we say, do these nicotine replacement medications, to include the lozenges, gums, and patches, do the exact same thing as smoking? And the answer is no. And so that's why I think it's valuable to understand that you're not overdosing these patients on nicotine when they're using these products, especially lozenges that are only 2 milligrams, or the patch that's a low dose. As you can see, the patch on the bottom is very low. So you're going to give the patient what I call a basal rate of nicotine when you're using the patch. And that's why combination therapy is so necessary, to even use the patch with gum on top of using Chantix, for example. So this is why we have to kind of get those levels of nicotine up for a good period of time while we use non-nicotine replacement therapies such as bupropion or Wellbutrin and the Chantix. So don't be afraid of combo therapy here. Other non-pharmacologic methods can be useful for patients who are really not wanting to use medication, so we have to work with them, assisting a tapering reduction, so encouraging them to reduce their smoking by 1/3 every week, and essentially hoping that they really get to 0 over time. And then, of course, there are now smartphone apps that can be used. Here's a couple of pictures: the Quit Now app and the Smoke Free app. Some of them do use the telephone counseling support, so you can direct them towards those if that's what they prefer. Again, combination therapy looks different for everybody and can be utilized in different ways. So you use the nicotine replacement with other nicotine replacements, such as patches and gum. You can use nicotine replacement with bupropion or Varenicline, and you can use a combination of non-nicotine replacements, such as bupropion and the Varenicline. It's helpful, I think, to ask the patient to document their use. So use a chart so that they can log what they're using, to follow up with them and to see how things are going. Bring it back like a blood pressure log, right? These are the resources that I wanted to share with you. Many options. MD Anderson is where I took the training course from. It's a 5-day course, gives you a certification, and very useful. And then the Quit Now is a very popular site. And then there's many others that can help the patient, essentially also with counseling. Psychologytoday.com, I wanted to direct you to, is a site that can hone in the resources that are available in your area. So use that. I've used it several times and found it very valuable. So what I want you to do is consider how you can incorporate tobacco treatment in your clinic and what resources are available in your area. So that's all I have for you today. Thank you.
Thank you, April. That was great. It really does outline the importance of smoking cessation for our patients, and also the complexity of it. I think that's probably a little bit of a barrier to a lot of people who don't do this frequently in starting these pharmacologic agents and nicotine replacement for their patients, because there's a little bit of an art to it. So this is really helpful. Hopefully we can share your slides with everybody after the presentation. And it was interesting to learn about, the percentage of patients from certain ethnic or racial backgrounds and income levels and their use, because I think, they have maybe higher levels of use, but also a lot of barriers to quitting as well. And that's, I think, where the services of people like Jennifer come in handy. I'm curious if you've experienced a lot of barriers as far as affordability of these medications. I know that Chantix can be quite expensive, but any other issues you've noticed or assistance that you've needed to obtain to help people get these medicines?
Overall, I think Chantix is going to be our biggest challenge, but everything else seems to be much more affordable. I think I've had a few patients who said the medications weren't covered, such as like the patches or what have you. The benefit, though, is there is options of purchasing some of these things over the counter. There is an over-the-counter options for many of these, which may be an option for people who can't get it covered by insurance. I mean, I'm surprised at some point that insurance wouldn't cover these sorts of products, because really, let's make sure that we quit versus continue to smoke and have more medical problems over time. So I think the Chantix is the biggest option. I think Jennifer could help us in understanding too. I think there's a lot of resources available, maybe coupons and patient assistance programs that can help these patients over time. But again, I think that we should think about maybe how we can incorporate the team in our clinics and the other modalities within our hospital system. So I think nurse practitioners have a great opportunity to maybe fill in the gaps of where the physicians see the patients, and maybe we can follow up with the patients over time. So I think that's an opportunity maybe for us to be useful in our clinics as well as nurse practitioners or physician assistants.
Yeah, that's a great point. The team-based care is probably key to this. There is one additional question in the Q&A. April, if maybe you want to take a look at that and we can type some responses to that. I'm going to go ahead and move on to our next talk. Just for time's sake, I'm going to introduce Dr. Gautam Nayak. He's our Washington ACC governor, here to share with us his experience in managing cardiovascular disease in patients with diabetes. I think we're all familiar with the changing indications for a lot of the diabetic medications now for our cardiac patients, and I'm excited to hear about his thoughts on this and where we're going from here with the management of both of these diseases together.
Great, thank you, Katie. I am going to actually potentially come off my video if I have an unstable internet connection, but I appreciate your introduction. I'm Gautam Nayak. As Katie mentioned, I'm the governor of the ACC chapter, and appreciate the opportunity to talk. This is a topic that I've been fascinated by for a couple of years now, just because it touches on so many different diseases, whether it's coronary disease, heart failure. Treating diabetes is something that I'm starting to kind of get used to, and full disclosure, I am I'm gonna stop my video here. Full disclosure, I'm married to an endocrinologist, so I think that I do definitely get additional insights. Can you guys hear me okay, Katie?
Yes, I can hear you. It was a little choppy before you turned off your video, but now you are on slide 2.
Perfect.
Type 2 diabetes, a pandemic. Perfect.
So as we all know, diabetes is definitely a pandemic. Over 30 million people currently have it in the United States, and about a third of our country actually has pre-diabetes. So they've already started to develop cardiovascular disease. And we spend hundreds of billions of dollars annually treating diabetes, which is really eating up a lot of our healthcare resources. And by 2030, we're looking at over 50 million people in our country with the diagnosis of type 2 diabetes. And why is that important to the cardiovascular community? Well, it's really driven by the macrovascular complications of diabetes. And by that, I mean heart attack, stroke, and peripheral arterial disease. This is the source of most of the morbidity and mortality in diabetes. And really, when we think of the newer agents that are coming out for treating diabetes, we're thinking about reducing these macrovascular complications. Now, traditionally, we've focused a lot more on lowering A1C and improving glycemic control, which actually reduces the microvascular complications of diabetes. So in that, we mean retinopathy, nephropathy, and neuropathy, which is obviously an important thing, and driven by your A1C levels, but oftentimes doesn't lead to as much mortality as the macrovascular complications. And certainly when we think of diabetes, we want to think about lifestyle. And if you focus on lifestyle, like with April's great talk about reducing smoking and all of the dietary things that Jennifer spoke about with improving food deserts, you're going to make a huge difference with macrovascular complications in diabetes. But ultimately, focusing on drug treatment and insulin kind of is where we end up. And it's interesting, the original drugs that were developed for diabetes, the focus, just like with type 1 diabetes, is on glycemic control. And it turned out by getting the glycemic control optimized, we actually increased the risks of obesity, hypertension, sodium retention. And so you started to neutralize the glycemic control effects of these drugs. And other than metformin, which definitely does reduce the risk of cardiovascular events, but as we all know is difficult to take due to side effects, we didn't really have much in the way of treatment for cardiovascular disease event reduction with diabetes drugs until the advent of the SGLT2 inhibitors and GLP-1 agonists, which I'm going to speak about a little bit in this talk. So SGLT2 inhibitors are really interesting drugs, especially for cardiologists who treat heart failure, because they work very similarly to diuretics. The sodium glucose cotransporter is located in the proximal tubule of the nephron, and it's responsible for 90% of glucose reabsorption. So if you block it, you get a very profound glucoseuria, which if you get that, it's very similar to the natriuretic effect of diuretics. So you get a profound diuretic effect, you get weight loss, and you get the lowering of systolic blood pressure to a modest extent. And when the blood sugar is high, like in diabetes, you get a much more pronounced effect because you just have more filtered glucose. And as the blood glucose normalizes, this effect starts to kind of diminish. So the risk of hypoglycemia with these medications is extremely low. And as it turns out, they reduce the risk of progression of diabetic nephropathy, which we'll talk about in a few minutes. Now, GLP-1 agonists work differently. GLP-1 is a hormone that we all secrete. It comes from the distal ileum, and it goes and it affects the pancreas and causes the pancreas to increase insulin release. But what it also does is it reduces the speed at which the stomach empties. And so that leads to early satiety and a lower appetite. So by giving a GLP-1 agonist, we can increase the levels of GLP-1 and make these effects much more pronounced. So patients that take GLP-1 agonists also get a pretty significant weight loss effect, lower appetite, and increase their insulin, which also lowers their blood sugar. So why is this important? Well, in 2008, the FDA, recognizing that a lot of the agents on the market were not really helping with cardiovascular events, but patients with diabetes were dying of cardiovascular events, started to make cardiovascular outcomes an important part of any new diabetes agent that was coming down the pipeline. And so we were following cardiovascular outcomes with all of these new agents. And it turned out with both the SGLT2 inhibitors and the GLP-1 agonists, we were seeing a significant benefit in cardiovascular events in patients that were getting these drugs just to simply treat their diabetes. And so about 5 to 6 years ago, a number of trials specifically looking at SGLT2 inhibitors and their effects on cardiovascular death, heart attack, and stroke were published. And Across the board, this was a class effect. We were seeing a significant improvement with these medications in reducing the risk of death, heart attack, and stroke. But what was interesting with the SGLT2 inhibitors was that you were seeing these patients actually have lower heart failure hospitalizations, which was pretty remarkable, maybe intuitive at the time, but then that led to further studies, which we'll talk about. On the flip side of the coin, the GLP-1 agonists similarly were found to reduce the risk of cardiovascular death, heart attack, and stroke in patients with type 2 diabetes and established cardiovascular disease. Now, there's a little bit of heterogeneity amongst this drug class in terms of these event rates, but the bottom line is that they got an FDA indication for this actual reduction in cardiovascular events. And the way I like to think of it, if you look at this kind of central illustration, is that the GLP-1 agonists are really great for patients with coronary artery disease and diabetes. There's kind of an anti-atherogenic effect because you lose weight and you just don't eat as much of the foods that perhaps might lead to atherosclerosis. And on the flip side of that, the SGLT2 inhibitors really have a nice hemodynamic effect. You get a diuretic effect with the drug because you're basically urinating out glucose, and you get a little bit of vasodilatation. And together, both of these agents lead to lower rates of cardiovascular events along the whole. And this is important to me as a cardiologist because of this kind of milieu that I see every day between type 2 diabetes and obesity. So if I can treat the diabetes and get the patients to lose weight, I can make a huge difference because I know both of these disease states have a direct myopathic effect. If you look at the atria themselves, diabetes and obesity lead to impaired left atrial function. That leads to higher left atrial pressures, exertional dyspnea, heart failure. It leads to fibrosis in the atria, which can lead to thrombus formation and strokes. And then, of course, you still ultimately see the end stage results of that, which is kind of the electrical phenomenon of atrial fibrillation. So diabetes, obesity, direct atrial myopathic effects, and we're also finding that they affect the left ventricle. Pre-diabetics have subclinical left ventricular dysfunction. And then as they start to develop diabetes, both the macrovascular and microvascular effects in the heart can lead to actually direct LV dysfunction. And we've all seen this. Patients coming in with obesity, diabetes, they have heart failure, their cath looks okay, and we're not entirely sure why they have it, but chances are they're seeing some direct myopathic effects from their disease state. And so understanding that kind of and seeing the lower heart failure hospitalizations with the SGLT2 inhibitors led to a couple really remarkable trials. So the DAPA-HF trial studying dapagliflozin and the EMPEROR-Reduce trial studying empagliflozin, Farxiga for dapagliflozin and empagliflozin as Jardiance, took really all comers with heart failure. 50% of the patients in these trials did not have diabetes. But they all had an ejection fraction less than 40% in class 2 to 4 heart failure. And it turns out that adding an SGLT2 inhibitor in with their guideline-directed medical treatment, and these patients were on excellent medical treatment. Over 20% were on Entresto. They were all on beta blockers, spironolactone. They had ICDs. When indicated, they had a BiB pacer. And there was a significant reduction in all-cause mortality on par with what you might see with, say, an ACE inhibitor or Entresto or in the original ICD trials. So really dramatic improvement. And if you look at kind of the addition of an SGLT2 inhibitor to standard guideline-directed medical therapy, you saw an additive all-cause mortality reduction. This was really remarkable because it's hard to get much better than what we've already done with drug treatment for heart failure, but SGLT2 inhibitors accomplish that. And so now we think of treating patients with HFrEF with what's called quadruple therapy. And about 2 weeks ago in the New England Journal of Medicine, this trial was published. It was presented at the European Society of Cardiology and got a ton of buzz, the EMPEROR-Preserve trial. So empagliflozin, Jardiance in patients with preserved ejection fraction. And so again, half the patients in this trial, large trial, did not have diabetes, but they got randomized to empagliflozin 10 milligrams or placebo, and their average ejection fraction was 54%. And there was a significant improvement in cardiovascular death or hospitalization for heart failure. It was driven, the outcome was driven by heart failure hospitalization. And so regardless of the presence or absence of type 2 diabetes, if you have HFpEF, they were seeing that there was a reduction in death and heart failure hospitalization. So whatever your heart failure phenotype, these drugs tend to work, whether it's HFrEF or HFpEF. Now, this trial was just published. We'll have to see if this becomes a class effect. I suspect that dapagliflozin trials are ongoing. But I think that this really is fairly remarkable because, as we all know, patients with HFpEF have terrible disease. It's half of our heart failure patients, and we have very little that we can do to treat them. The SGLT2 inhibitors may make a difference. So great drugs, but things to know about them, the side effects. This is probably why a lot of us shy away from prescribing these drugs. And the things you need to know about are right here on the slide. So genital mycotic infections, you're essentially urinating out glucose, so high risk of fungal infections. And so we all need to get comfortable talking to our patients about appropriate hygiene when you start these medications. The women are probably at a bigger risk, and then uncircumcised men. So I think that just having this discussion up front with the patients is obviously very important. Rarely you can see diabetic ketoacidosis, and it's with euglycemia. So patients will come in with normal blood sugars, but acting as if they have DKA with abdominal pain, nausea, vomiting, shortness of breath. So you need to think about that in patients on SGLT2 inhibitors. And I've seen one case of it as an inpatient here in the last few years, but it's pretty rare. They're diuretic drugs, so you're going to see volume depletion and potentially hypotension at times. So you may need to modify their diuretic regimen or their medical treatment if you are seeing this. And canagliflozin did have an FDA warning for increasing amputation risk. That was removed last year. But you do want to use caution in patients that have had severe peripheral arterial disease or neuropathy. And these drugs are not really recommended if the GFR is less than 45. So you'll see a slight drop in the GFR, just like you would with an ACE inhibitor or an angiotensin receptor blocker when you start it. But that's not a big deal. What you really want to do is avoid using this in patients with significant renal dysfunction out the gate. And there isn't any safety data in pregnancy or breastfeeding. And again, these are used for type 2 diabetics. Now, GLP-1 agonists, different. These are the injectable medications, and they delay gastric emptying. So you're going to potentially see some nausea, and you're obviously going to see some weight loss if patients are getting early satiety. And rarely you can see things like pancreatitis. So you just want to be careful in patients that have gastroparesis or prior gastric bypass surgery or other types of bariatric surgery. You just want to use these medications cautiously there. Interesting, semaglutide or Ozempic, there was a signal that it increased retinopathy, thought to be driven by the drop in blood sugar. This is kind of a very rare issue. You just want to make sure that your patients getting these drugs are getting regular eye exams. Injection site reactions are reported. I have yet to see them, but I'm sure as we learn more about these drugs and use them more frequently, this might be an issue. They're once a week. Most of these are once a week. There is a daily GLP-1 agonist, but I think that the injection site reaction issue is pretty uncommon. These have a little bit more of a liberal GFR. You just want to avoid it if the GFR is less than 30 or if they've had a history of medullary thyroid cancer. And again, no safety data in pregnancy or breastfeeding, but generally speaking, pretty safe medications. So the column on the left here is kind of how I look at the current paradigm for treating diabetes. If you're going to give a drug to lower glucose, you want to give a drug that's going to lower cardiovascular risk because we know the macrovascular complications are what drive morbidity and mortality in diabetes. And so that's what I have listed here on the left. On the right are the drugs that simply lower glucose. You get no cardiovascular benefit. And so perhaps you may not want to necessarily prescribe them first line. However, what I've shown here in the middle is an analysis. Matt Slagle, one of my colleagues, he's a pharmacist at Confluence Health, put together for me in terms of the cost. And this was about 18 months ago. This has changed a bit. But as you can tell, it's extremely expensive to just jump to an SGLT2 inhibitor or GLP-1 agonist at times. Again, depending on the patient's insurance, when metformin and glipizide are $4 a month. So you have to take that into account as you start to think through how you're going to, you and the primary care provider are going to treat the patient's diabetes. But what I'm seeing is that the coverage for both SGLT2s and GLP-1s as the indications expand is getting significantly better. So it's worth trying, even if in the end you may have to kind of frame shift to less optimal medications. So just to kind of give you some clinical pearls here on the SGLT2 inhibitors, again, don't want to belabor this, but think about the genital fungal infections as well as the euglycemic DKA. And also, you may need to adjust the diuretic dosing, and you want to remember the renal indication. And for GLP-1s, nausea is common, so you just want to start at the lowest dose and titrate up slowly. You want to eat smaller portions, which will help with the weight loss. And you want to be mindful of active pancreatic disease or gallbladder disease. And really what I want to remind people is this is really these are our drugs. It's all one system, the cardiorenal metabolic axis, but these are our drugs. As cardiovascular professionals, we need to be very comfortable in prescribing them and really focusing on treating the patient with a debilitating condition of diabetes, which can lead to significant risk for heart attack and stroke. And I would encourage you all to kind of use a team-based approach. Engage the primary care provider early. You know, we're using a lot of very expensive medications these days, whether it's the GLP-1s, the SGLT2s, the PCSK9 inhibitors, Entresto, the DOACs, Brilinta. I mean, just it becomes very, very challenging. And so you want to use a multidisciplinary approach when you think about chronic disease management, rather than focusing on the acute events, heart failure, hospitalizations, et cetera. Try to get on board early with your pharmacists, use the medical science liaisons with the different companies to get education and get these patients on these medications in a way that makes sense for them and their finances, their insurance coverage, and their disease state. But a team approach is critical. Thank you, and I would love to have any questions.
Thank you so much, Dr. Nyack. There is one question in the Q&A box here from Jennifer George asking about any studies or research on heart failure, patients with heart failure and prediabetes or no diabetes, if they're perhaps less likely to develop diabetes when on these quadruple therapies. Either due to weight loss or perhaps blood sugar control or combination of any of those. Have you seen anything in the current research on that?
Oh, that's a great question. I think that's kind of probably essentially the billion-dollar question. My sense is we're going to have further analysis from Emperor Preserved and Emperor Reduced, as well as DAPA, in terms of the long-term implications of starting SGLT2 inhibitors in patients without diabetes or pre-diabetes. That was followed. I suspect that will be adjudicated in the coming years. But my suspicion is that if you can get patients to lose weight, improve their glycemic control, you're going to see a benefit in terms of reducing heart failure, cardiovascular events, preventing it probably. The original trials with these drugs kind of suggested that, and I think we're starting to learn more about it. So my suspicion is we're going to have that data soon, and it would be really surprising if it was what we thought it was going to be, which is pretty positive.
Great, thank you for that. I had one other thought just as you were talking about the kind of general cardiometabolic state that these patients are in with their the cardiovascular disease and the diabetes and the renal dysfunction, and the slide you shared showing the atrial myopathy developing early on, probably clinically undetectable for quite a while. And then you use the term end-stage electrical phenomenon of atrial fibrillation, which I thought was really interesting because often we see these patients present with atrial fibrillation and we're thinking this is the thing we need to treat, when it was probably years of these chronic conditions and leading to this pro-inflammatory state, and their weight and their diabetes as well, that develops this kind of atrial myopathy that you discussed. So I thought that was really interesting.
Does Zoom have like a high five emoji here? I think summarize the entire. Yeah, that was perfect. I think that, and without disrespect to our EP colleagues, but I think that we've all seen patients present with strokes, and then like 3 years later they come in AFib, right? But they had a stroke 3 years before, and it wasn't clear, and they have all the risk factors in the world. So we give them Plavix, or we give them some other medication that is going to be an antiplatelet agent. But what it is probably high left atrial pressures, atrial fibrosis, and clot formation. And I think that we have to start to look at atrial fibrillation with a little bit more nuance, because some patients, it really is the end stage of a lot of atrial fibrosis that's occurred. And if you talk to the electrophysiologist, they'll agree. I mean, they get in there to do an ablation and the entire atria is scarred up. And so it's hard to do much at that point. So my sense is that if we can reduce the diabetes, attack it when it's pre-diabetic or even before, and get patients the weight loss to take effect, I think it will be extremely helpful for these sorts of conditions. Yeah.
Well, great. Thank you so much. I'm going to move on to our next speaker before we have a little break here. I'd like to welcome Joel Reiner, a physician assistant and colleague of mine here at Confluence Health Cardiology. Joel is our resident lipid specialist. He's been instrumental in development of our PCSK9 inhibitor approval process, a wealth of knowledge for our department in lipid management. So he'll be talking to us today about the most recent guidelines on management of patients with persistent hypertriglyceridemia. Joel.
Thanks, Kitty. Can you guys see and hear me okay?
Yep.
Great. So this topic actually has been kind of on my radar for a while. It's been an area of lipid management that's been, it's kind of waxed and waned over the years as far as treatment and the importance of treatment. And I was very excited to see the ACC come out with a very nice decision pathway to help us clinicians and obviously for our patients to do due diligence on an area of lipid management that's incredibly challenging to treat. And to kind of segue back to Dr. Nayak's talk about type 2 diabetes, and one of the predominant lipid abnormalities in type 2 diabetics is hypertriglyceridemia. And in fact, you can often predict loosely who is going to develop type 2 diabetes really early on in the scale of their hypertriglyceridemia. And that's in the setting of metabolic syndrome, which we're all pretty familiar with at this point. But so it dovetails into type 2 diabetes, which then dovetails into cardiovascular disease. And we are seeing, some great movement in the LDL world. Obviously, as Katie mentioned, PCSK9, statin's been around forever. And we're starting to now see further development in therapies, both lifestyle and medical therapies for hypertriglyceridemia, which is exciting. So our rationale is like, well, why do we care? What is so important about hypertriglyceridemia? And so first, we kind of want to define it to a bit, because if you look at the lipid panels and at Confluence Health, we use Epic, and you get these labs back, and everything looks good, quote unquote. LDL's 65 and total cholesterol's 110, but the triglycerides are 400, and it's red. It's like, oh, what am I supposed to do with that? The role of lifestyle interventions in treating this, there's some really interesting information and data coming out about that, which we'll highlight a little bit. And the role of statin therapy, is really foundational, which a lot of folks may or may not know. And then who do we use non-statin based therapies with? And then also, how do we use it in what order, where do we start, doses, and so forth. So some key points on this paper, and so if you want the full document, it's on the ACC website. It's actually a really for a consensus document, it's a fairly easy read, to be honest. So I would encourage you to check it out. But it really brings to the forefront that elevated triglycerides, and we'll define what that is, are one of the risk enhancing factors for further cardiovascular disease. And we start kind of testing people around the age of 20. There are some conditions that we test kids for. I don't do pediatrics, but there are some genetic conditions that do occur in children. And unfortunately, we are seeing more and more hypertriglyceridemia in our children that are obese and unfortunately have developed type 2 diabetes at a very young age. But we're going to, for this talk, we're focusing on the adults. So we look at lifestyle interventions, but our key groups are kind of 4 groups: are the folks that have cardiovascular disease, folks that have diabetes and have not had cardiovascular disease, our high-risk primary prevention groups, so multiple risk factors, high cardiovascular risk scores, and then the other subgroup of patients, smaller but also critically important to identify, are our folks with the severe hypertriglyceridemia, and basically triglycerides well over 1,000, and that are high risk for pancreatitis. So despite us putting patients on statins, which we should all know by now is the thing to do, and as Jennifer talked about, kind of the goal of 80% or better, that event rates in patients that have elevated triglycerides, we continue to see high. We see it all the time in patients that come through our clinic and end up having to have a repeat cath and have advanced disease. Often those patients will have elevated triglycerides despite having an LDL that's at or near goal. And so how do we define this? Ideally, it's a fasting lipid panel. And, we've gotten, over the years, we've gotten away from fasting lipid panels because our LDL drugs have gotten so good, and that we kind of tend to laser focus on LDL. And however, to really get a good basal assessment of what a person's triglyceride level is, fasting is ideal if you can get it. But often in our rural populations, it's hard. They've traveled several hours away to the clinic, and they're sitting there and they wolf down a hot pocket on the way down to the clinic. And so you do the best you can, but fasting is ideal to get some accurate data, but on a non-fasting, it's 175. So between 175 and 500 is mild to moderate, and then severe is over 500, and particularly over 1,000 milligrams per deciliter. That's again your severe hypertriglyceridemia. So that should really jump out at you. What we look at too is, and we'll get more into this as the talk goes along, but the persistent hypertriglyceridemia. So despite doing something, so whether it's lifestyle, statins, or other therapies, you're still having trouble getting their lipids, their hypertriglyceridemia down. That's when we start to use some of these more non-statin based therapies, which we'll highlight. Secondary causes. This is really, really important. I think we need, as clinicians, we got to look at what else can be causing their hypertriglyceridemia. And there's a really comprehensive list, and it's actually super fascinating to look at what other conditions, but also medications can do to triglycerides. But really at the foundation of what we're trying to do is lifestyle, and is really critical. Again, touch base, LDL, kind of no brainer. We want to get people in LDL therapy, particularly those that are with coronary disease or at highest risk. Some of the other, treatments are fibrates, which we'll talk about, and the prescription grade omega-3 fatty acids versus the over-the-counter. We'll discuss that as well. There's been some recent data on clinical trials that I do want to point out. This isn't a clinical trial talk, but I wanted to bring up a couple of things because if you follow the recent literature and the recent publications by ACC and others, there's been some concerns about the disparity in clinical trials, particularly with omega-3 fatty acids in the treatment of hypertriglyceridemia and cardiovascular disease. Two fairly, well, technically 3 trials, but 2 that are fairly robust, Reduce It and Strength, recently have been published. Reduce It was in 2019, used a EPA only omega-3 fatty acid prescription therapy and we saw significant reductions in cardiovascular disease. And that kind of set the world on fire as far as like, holy smokes, this is really impressive. We're talking, we're talking a significant reduction, around 25%. And there was a lot of question about that. It's like, wow, how did this happen? How did we miss this? How come we were not seeing this in previous data? And then to follow that, strength came behind it when it looked at a mixed EPA-DHA combination. So like if you wanted to think of it, Lovaza, as far as throwing a name out there, that actually did not show any cardiovascular benefit. And so it was a bit puzzling. And so, and then a much smaller trial, Evaporate, looked actually at plaque regression, again with an EPA only, i.e. Visipa, and showed plaque regression in CT scanning in a very small trial. So there's lots of different data. What we did start to see, though, was some, we didn't see harm outside of some side effects that, as Dr. Nayak was just actually talking about, atrial fibrillation. We started to see increasing rises in AFib in both the EPA and the EPA/DHA group. So some very interesting disparities in the clinical trials. So just as a quick review, REDUCE-IT looked at what the reduction in CV events was, and we saw again a statistically significant improvement in reduction in cardiovascular events with 2 grams BID with meals. You can see here in this graph that the risk for MACE was at 0.75, and the risk for cardiovascular deaths was at 0.8, so anywhere from 20 to 25% reduction. And that happened fairly soon, within about a year of treatment. And this study went out for almost 5 years. And again, that's looking at the icosapent ethyl EPA. So to use a brand name, it's the only one out there right now called Visipa, 4 grams a day. And by the way, I should say I have nothing to disclose. So there's no, hopefully no impression that I'm pursuing you one way or the other. But right now, Visipa is our only prescription grade EPA only therapy. When you looked at Evaporate, again, that was looking at icosapent ethyl. Small group of patients, though, looked at how lowering triglycerides on background statin therapy actually did show change in plaque volume by CT scan. So that would postulate that there's reversal and or regression of plaque with EPA only non-statin therapy added onto background statin therapy. When we look at these trials and we look at that several of them, again, as I've mentioned, have created a little bit of disparity because they're not head-to-head. They're also not the same formulation. And in fact, when they used placebo, they looked at a mineral oil placebo and a corn oil-based placebo. And you might think, well, what's the big deal? Well, actually, it turns out it is a big deal because of some of the inflammatory effects of mineral oil versus corn oil, and also changes in LDL cholesterol in some of these placebos. The point is this, is that I think the story's still being unfolded. I think one thing that we do know is that EPA alone seems to be better at this point than for sure than over-the-counter supplementation, because there's such a wide variety of what is in there. Lovaza, which is your typical mixed omega-3 fatty acid that is available and is generic, is better than over-the-counter, but not as good as 100% EPA. But also keep in mind, both of these agents do cause an increased risk of AFib. And so if we are in a population of patients, and it's growing more and more, that are either have AFib or at increased risk of AFib or have paroxysmal AFib, it's something to keep in mind that if they're on a high dose omega-3 fatty acid and they're having symptomatic AFib, that there may be a relationship to that. So need to definitely pay attention to that. One thing I did want to point out too is also secondary causes of hypertriglyceridemia, as I mentioned. This list is pretty startling, and I'm sorry, it's a little hard to see because of the size of the slide. But I think a couple of things I wanted to point out to you is that particularly in if you see younger people in clinic, and particularly athletic men and women, they come in and they're all jacked. They look like, you know, they've been in a CrossFit gym, and their doctor sent them to you because they have hypertriglyceridemia. The first thing you should think about is anabolic steroids. And believe it or not, it is all the way into the high school kids. So you need to pay attention to that. But our usual players, I mean, poorly controlled diabetes, chronic kidney disease, rare, but people can have familial chylomicron syndrome. But be aware that in some of the cancers and lupus, some of these other things can cause hypertriglyceridemia. So this is not a comprehensive list, but it's pretty detailed. And again, in cardiology, we use beta blockers, we use thiazides, we use loop diuretics, we use bile acid sequestrants. A little comment about that. We don't use that very much anymore because, you know, Zetius and PCSK9s are so much better at reducing LDL. But patients that are still on bile acid sequestrants, that can also cause a raise in their triglycerides. So something to be aware of there. Some of our oncology drugs too, like tamoxifen particularly, can cause it. So lots of things, obviously obesity, metabolic syndrome, you know, really bad diet can be a key. So getting a fasted lipid panel is ideal. It really helps us assess both not only baseline status, but also how are we doing on therapy, and then you know, what the risk is of pancreatitis. So we kind of clump our patients into these groups, you know, those with cardiovascular disease and those without. The bottom line is that the foundation of our therapy is that we need to evaluate and manage our secondary causes, get diet and lifestyle going, which I'll highlight here in a second. Look at guideline-directed statin therapy and optimize the statin adherence, which is a whole nother talk that we go into. Optimize glycemic control. Dr. Nayak did a great job on looking at some of the novel new agents. And interestingly enough, both those agents reduce triglycerides, and so help improve glycemic control, but also their lipid profile. If despite doing all that, they still have hypertriglyceridemia, then we can start to look at doing some other add-on therapies, which we'll go into a little bit more detail. You know, what's interesting is looking at how well lifestyle does work. It is obviously probably the hardest thing for people to do, but it can make a huge difference. Even in patients that have triglycerides well over 500, by reducing their sugars, reducing their total fat intake from saturated fats more to plant-based fats, abstaining from alcohol as much as possible, getting their exercise program going, and losing weight can have significant changes in their lipid profile. In fact, much more significantly so than LDL or even HDL. Because we harp on exercise about raising HDL. It might move the needle 1 or 2 milligrams. What you really want to do is harp on aerobic exercise or any exercise for that matter in the reduction of triglycerides, particularly if they have elevated triglycerides. And so here's just some examples. I mean, you could see significant reductions in triglycerides in patients with weight loss, dietary modifications, particularly those that drink a lot of alcohol. If you get a patient to reduce or eliminate their alcohol, you can significantly reduce their triglyceride reduction. Also, what's interesting, intermittent fasting also has a very powerful effect, as does low carbohydrate diet. And then, as I mentioned, physical exercise. So these are just some basic things that you can start with. You know, get a diet that reduces the saturated fat clearly, but also uses plant-based fats, and then increases their protein. Again, you want it, it's a tough balance because protein, people think beef, and a lot of beef has a lot of saturated fat. So you have to help patients kind of coach them through that. Obviously, have a registered dietitian or nutrition coach that you trust and is certified makes a huge difference. Limiting the high glycemic index foods. Also, so, you know, maybe somebody eating a banana every day, even though it's got a lot of potassium in it, it's a high glycemic index food. It may not be the best for them, particularly if you're really trying to help them lose weight and move the needle on their triglycerides. Exercise, bottom line is got to move. Anywhere from 150 minutes of kind of moderate exercise, i.e. walking, to more like 75 minutes of vigorous, which is, riding a stationary bike, or, going to a fitness class, and additional weight loss really makes a big difference. And then, as I mentioned, the alcohol. Sorry about this slide. It's super busy. It's in the document, but this really breaks down based on person's triglyceride levels, kind of what the effects, but also what you can do from a lifestyle and medication standpoint, and what you can expect as a clinician in some of these patients. The dietary patterns are really interesting. There's a lot of research going on right now in this area. Unfortunately, we would, for years and years and years, we're telling people eat low fat, and go high carb. That's probably the absolute worst thing we could do for people. Better yet, particularly with patients that have hypertriglyceridemia, they need to eat a lower, healthier carbohydrate diet, a little bit higher plant-based fat, and can have significant reductions in their triglycerides, as well as a higher protein diet. Again, you got to pick your protein. It can't really be loaded with saturated fat, but it also can reduce triglycerides significantly. And then intermittent fasting is an interesting phenomenon that's caught on, over the last few years. It's very tricky. It needs to be done by, a dietitian or nutrition coach that's really knows what they're doing, but can have significant reductions in triglycerides for certain patients. Everybody's going to come in saying, hey, I'm doing keto, or I'm doing, Atkins or something like that. And they're going to ask us as clinicians what we think. It pays to do some research on these diets, obviously refer to a dietitian as well. What I find is, I like to individualize things. I've got some patients that have done amazingly well on a keto diet, and other patients have been an absolute disaster. So I think you need to kind of give people a little bit of grace, but also work with them on things and see what works best for them. So on our patients with cardiovascular disease and triglycerides that are elevated, and when we talk about this, basically in triglyceride anywhere from 150 to 500, we'll just put it in that range. Again, look at their secondary causes, optimize their lifestyle, get their glucose under control if they're diabetic, but then drill down on their LDL, get them on a moderate to high intensity statin therapy, okay, typically high if they have cardiovascular disease, and get their LDL below 70. If you've done those things, then you can look at additional therapy. And icosapent ethyl rises to the top because it has, as of right now, the best cardiovascular outcome data, as well as it has the best, I wouldn't say the best triglyceride lowering data, I'll show you that in a second, but it has the most consistent and also has anti-inflammatory reduction data, which we postulate actually is the real benefit behind why EPA is actually superior than even mixed EPA DHA products. But this is a shared decision-making process with the patient. They need to, be willing to do all these things. It's a lot of work. And us coaching them every, 4, 6, 8, 12 weeks really helps improve adherence to the goal. In our patients that do not have cardiovascular disease, this is a little bit of more of a challenge, to be honest, because outside of the lifestyle therapies and so forth, the medical therapy and you want to look at this from a primary prevention has not been super robust. And so what we're looking at is we want to look at what will this person, eventually develop into, okay? They have type 2 diabetes. We know where they're headed. We just don't have a lot of data on using icosapent ethyl. We have a little bit of data on fibrates. We have the most data on statins, and we have the most data on lifestyle. So we know those things work. But as far as some of these additional non-statin therapies, it's a little bit less clear. We suspect, though, as future trials come out, that we're going to see that these do make a huge difference. But really, if they're high risk, you want to get them on obviously guideline-directed statin therapy. And that may not be high intensity, it may be moderate intensity statin therapy. And obviously the lifestyle things, and then moving towards icosapent ethyl if needed. Patients that have hypertriglyceridemia that also have other enhancing risk factors are critical. So this is the list, and I wanted to point out a couple of things that I think are really important. Obviously, family history of premature cardiovascular disease, someone that has persistently elevated LDL despite being on statin therapy, that's a red flag. Jumping down to also lipoprotein A, I'm kind of a big lipoprotein A guy, so that also increases risk. And elevated hsCRP. The reason I bring that up is that in all the clinical trial data, both on mixed omega-3 fatty acids and 100% EPA, across all quartiles, hsCRP dramatically is reduced. And so, patients that have hsCRP are increased risk for both MI and stroke. So we can look at that as something that can be treated, quote unquote. We don't measure it a lot, but that may be one of the biggest benefits that we see of mixed omegas. But identifying those patients that have those enhanced risk factors will really take us through a nice pathway of like, hey, who do we need to be much more aggressive of, particularly increasing their statin therapy or intensifying it and potentially adding something else in that high risk group. The lower risk group, we can probably stay with lifestyle and feel pretty good about that. Now, our group that has triglycerides over 500, that really should catch your attention. You want to get on those folks sooner than later. And again, I use statins. And then in this case, this is one of the few cases we actually flip on the diet and we go to a very low fat diet because they typically have some kind of chylomicronemia syndrome that makes it incredibly difficult for them to metabolize fat. That's another group that you'll want to optimize their glycemic control, particularly they may already have type 2 diabetes. Statins work really well in this group. Don't be afraid to use them. Particularly atorvastatin actually has an indication for this group, anywhere from 40 to 80 milligrams. Despite what their LDL is, to be honest, I would get them on it. And really, though, they also need to be screened for pancreatitis. I've had several patients referred to me that have either been hospitalized for pancreatitis or have persistent triglycerides over 1,000, and we're working on ways for them to get a much better control. But it is usually a combination therapy of fibrates, omega-3 fatty acids, statins, glycemic control, lifestyle. It's everything. So I treat these folks very aggressively, almost just like our ASCVD patients. So when we're looking at treatment plans, I think it's pretty straightforward in that our adults, again, greater than 20 years of age, that don't have cardiovascular disease or diabetes and do have elevated triglycerides, lifestyle is foundational therapy. Really look at what their secondary causes are. That's usually where you're going to find the answer. And if you can mitigate some of that, then you can make some significant improvements. And our folks that despite doing that, have persistent fasting triglycerides that are high, over 500, getting them on fenofibrate or a prescription omega-3 fatty acids, particularly with your goal of reducing pancreatitis, is the key. And then in our patients that are a little bit older, have advanced cardiovascular risk, you want to initiate or intensify your statin therapy, and then continue to move through the spectrum of lifestyle, and then add fibrates or prescription strength omega-3 fatty acids, not only to reduce cardiovascular events, but also to reduce their risk of pancreatitis as well. And again, that group that's well over 1,000, we're looking at a very low fat diet, 10 to 15% of their calories, less than 20 to 30 grams. So if you look at any label, you're going to realize that that's a really intense diet. And again, all these patients would really benefit from an RD consultation. So I often get asked, like, hey, what can I expect when I put my patient on therapy? And so I wanted to highlight a few things. So this is kind of the spectrum of lipid management for the most part. I left a couple things out because they don't have a lot of indication in the group that I'm talking about, but ezetimibe or Zetia can reduce triglycerides by about 8%. Fenofibrate can reduce triglycerides by 40 to 50%. What's really interesting about fibrates, though, the only clinical trial benefit on fenofibrates is with monotherapy. In combination therapy with statins, which is often how we're used, there's neutral to basically no cardiovascular benefit. So that's and that's despite lowering triglycerides. So it's a little puzzling on why that is, and nobody's really studying that right now. So more to come on that. There's been some newer fibrates in the pipeline that may shed some light on that. PCSK9 inhibitors, so Repatha, Praluent, those are injection cholesterol drugs, mildly reduce triglycerides 10 to 20%. Our omega-3 fatty acid and icosapent ethyl. Now, this is prescription grade only. This is not over the counter. Can reduce triglycerides 15 to 30%. So again, not a huge, robust reduction in triglycerides. That's what you would expect. But again, I think some of these other anti-inflammatory factors may be really the benefit. As Dr. Nayak was talking about, SGLT2 and GLP-1, they actually both reduce triglycerides and improve cardiovascular outcomes. So by improving glycemic control, they have a subsequent benefit on lipid metabolism, which then also improve cardiovascular outcomes. Statins can reduce triglycerides, again, by a modest amount, although to be fair, I've seen atorvastatin reduce triglycerides by up to 50%. It's more on a case-by-case basis. But they, double benefit here. They reduce triglycerides and LDL. And typically you want to use a range of anywhere from 20 to 80 milligrams of atorvastatin and 10 to 40 milligrams of rosuvastatin. Those are kind of my two go-tos that I tend to use on patients that can take statin medications kind of consistently. And so just to review the non-prescription fish oil preps, the dietary supplements, their consistency is all over the place. They've got lots of other crap in them that don't really help us. And I'll be totally honest, up until a few years ago, I was just like, yeah, just go to Costco and get the maximum strength omega-3 fatty acids. I'm not doing that anymore. I'm either using the generic omega-3 esters or the EPA, depending on insurance, honestly, because of the consistency. They have been studied. And I feel that outside of the atrial fibrillation increased risk, that they're well tolerated and safe and do have good clinical benefit. And so this is a nice little handout that I often like to use with other clinicians is basically this kind of the mechanism of action. We think, it reduces, as I said, reduces mildly triglycerides. It probably has an anti-fibrotic effect as well as an anti-inflammatory effect. The REDUCE-IT trial was the first that really looked at this 100% EPA. There are some side effects, just so you know. Again, atrial fibrillation is probably the number one that we're paying attention to. And there has been some mild increase in bleeding, although it is like in our patients that are on aspirin, Plavix, and omega-3 fatty acids, we haven't seen any adverse bleeding that would cause them to stop the agent, but there might be some increased bruising that we do see. And I will stop talking and answer some questions.
Great, thank you, Joel. That was a lot of really great information. I know you had to pack it in a short amount of time. Thanks for highlighting the guideline. I printed it out myself the other day, and it's really helpful, all those tables to kind of break it down easily for people to kind of get to the best information quickly. Also highlights the importance of having a lipid specialist in your clinic, because this is it's a specialty and a specialty for sure. And we appreciate having you as a resource for our patients.
Sure.
I was curious if you could talk a little bit about sort of the more advanced lipid panels or lipid tests that you use in your clinic, because when we traditionally draw a lipid panel on patients, we get very limited information: the total cholesterol, the HDL, the LDL, the triglycerides, and some of those can be affected when the triglycerides are significantly elevated and may not give us the overall picture of a patient's risk. So what panel do you use and how do you use it?
Yeah, so I use the Cardio IQ panel from Quest. And so I think pretty much every institution probably in at least the Pacific Northwest uses Quest for some, Quest Diagnostics for a lot of their lab work. And the reason I use it, it kind of is an all-in-one package in my mind. So it has the typical lipid panel. It gives you a direct LDL. It also gives you a HS, well, you can add some things to it, to be fair. HSCRP gives you lipoprotein A, ApoB. It also gives you LDL particle number and size. And I didn't mention that a lot in this talk because the guidelines really didn't talk a ton about it. But here's the deal. So basically, the higher your triglycerides go, the lower typically your LDL is going to be, quote unquote, calculated on a typical lipid panel. Various reasons why for that. There's actually a new algorithm called the Martin-Hopkins method that is able to kind of mathematically weed through some of that. But what happens is that the LDL itself changes. The LDL particle goes from a normal to large size particle, and we develop these small, dense, very cholesterol-rich particles. So think of it this way: if you had to fill a room full of balloons, what kind of balloons do you want? You want big ones that kind of just bounce around the wall, versus if you have a room full of small balloons, the same volume, they are just pounding the arterial wall, if you think of it that way. So think of the LDL particle just pounding the arterial wall with these small, dense little particles. The other part of that is that the endothelium, the size of these LDL particles gets sucked up into the endothelium when they're much smaller. What drives all that is hypertriglyceridemia. And so along with that is suppression of HDL. So a typical pattern, particularly in our type 2 diabetics or our metabolic syndrome patients, is we've got triglycerides that are 200 to 400. Your HDL is in the 30s, maybe even the 20s for guys. For women, an HDL of maybe 35 to 45, which is low, and an LDL of 80. And you're like, that's just, it doesn't quite fit, right? Well, when you measure that 80 milligrams of LDL cholesterol, their particle number, so a particle number should be under 1,000. That particle number might be close to 2,000, even though their LDL is 80 milligrams per deciliter. So it's a disconnect. So again, segue a little bit there, but the Cardio IQ panel helps me kind of sort through some of that and decide decide which therapy we're going to go for. So the good news is statins kind of take care of a lot of this. They reduce the LDL particle number dramatically. Obviously, they reduce LDL, but they also reduce triglycerides. And so they take some of these, big fat chylomicrons and just shred them. And so get rid of that, and which helps. Doesn't move the needle on the HDL. That should not. I mean, honestly, we shouldn't even be talking about HDL per se with patients anymore. We should focus on their triglycerides and their LDL. The HDL is going to do what it's going to do. What we can really move the needle on is triglycerides and LDL. And you don't need a special diagnosis for the Cardio IQ panel. I mean, hyperlipidemia and CID, mixed hyperlipidemia, that all works. To interpret it might be a little different story, and so I can help people do that. So, and I mentioned lipoprotein A. I use it for a lot for that. I find a lot of lipoprotein A out there, which is a whole nother talk. Happy to get that at some point. But that also is, as I mentioned, is an enhanced cardiovascular risk factor. And so that on top of high triglycerides, high LDL particle numbers, just a recipe for aggressive cardiovascular disease, particularly in our younger patients. We're seeing it all the time.
Yeah. So there is one question in the chat, but I want to give us a little bit of time to have a break. And I think Joel could probably talk for another hour on this question that's in the chat. So I'm going to let you respond virtually and then, or in text. And then I want to give us just maybe a 5-minute break. We have Dr. Savla up next to talk about hypertrophic cardiomyopathy. We're just about 5 minutes behind right now, so we'll plan to maybe start that at 10:45 if that works for everyone. So I'll let Joel answer the question in the Q&A, and then we'll take a short, I guess, 7-minute break here so people can get up and stretch and refresh your coffee or whatever it is you're drinking this morning. And we'll plan to start Dr. Savla's talk at 10:45. All right, so it's 10:45, and I see Dr. Savlas here. Welcome. Thank you for joining us. I think we'll go ahead and get started so we give you all the time that we allotted for you to talk. Let me just fix my computer here. So I want to introduce Dr. Savlas. She's an acting assistant professor at the University of Washington with clinical practice at UW Medical Center and Harborview, practices in general cardiology with a focus on genetic cardiomyopathies. Also serves as a site director for a cardiology fellowship program at Harborview and course director for cardiology portion of first-year medical student curriculum at University of Washington. So she's here to talk to us today about hypertrophic cardiomyopathy. Welcome, Dr. Savla.
Thank you. Hopefully you guys can see my slides here.
Yes, it looks great.
Okay, perfect. So today I'm going to talk to you about hypertrophic cardiomyopathy and specifically some pathophysiology and current treatments for hypertrophic cardiomyopathy, and then mixed in will be some things that are updated from the guidelines that were just released in 2020 about how we should care for these patients. Okay, I have one disclosure that I served on an advisory panel for myocardia, and that will come up during this talk. So I'm going to start with a case. So this is a 47-year-old man that was referred to my clinic after he was found to have a murmur that was heard at sleep clinic, and this is his echocardiogram. And so the report that we got from this had a lot to it, but nothing that specifically mentioned hypertrophic cardiomyopathy. But I want to point out a few things, which is that they had mentioned that there was flow acceleration in the LVOT because there was basal septal hypertrophy and the measurement was 21 millimeters. And then that they also mentioned that there was chordal systolic anterior motion and a dynamic flow acceleration in the LVOT, and that the peak CW velocity in the LVOT was 3.3 centimeters. So then this led to a question, which was, what does that report mean? But for me reading that, the question is really, does this patient have hypertrophic cardiomyopathy? So over the course of this talk, we're going to talk about the overview and pathophysiology of hypertrophic cardiomyopathy, what's involved in the initial workup, and then the management of hypertrophic cardiomyopathy, and then we'll go over some conclusions or summary statements. So how do we define hypertrophic cardiomyopathy? So it's characterized by having unexplained LV hypertrophy in a non-dilated LV chamber. And then typically the LV maximal wall thickness is greater than 15 millimeters, with folks that have wall thicknesses between 13 and 15 millimeters defined as being borderline. This is a sarcomere-related set of diseases in which a number of sarcomeric proteins can have gene mutations present. The most common mutations occur in the MYBPC3 protein, or the myosin binding protein C, or in NYH7, and that accounts for about 85% of these genetic abnormalities. The gene works in sort of the gene abnormalities work in a dominant negative mutation, which means that the dysfunctional protein is actually antagonistic to the wild type protein. And then this is a disease of incomplete penetrance, which means that the phenotype can be really variable between families, with some folks in a family having more severe presentations of disease and other people having milder presentations, and also people presenting at various ages. Hypertrophic cardiomyopathy may actually be more common than we think. So the incidence has previously been cited as 1 in 500, but with the more people getting genetic testing and then additional advanced imaging techniques like cardiac MRI being more common, we may be actually able to pick up more folks than we think. And so the revised estimates sometimes say something like 1 in 200, but I think it's definitely more common than 1 in 500. So the presentation of disease, like I mentioned, is variable. So people can present with those LV outflow tract obstructions, which was mentioned in that echo report. They can also present with diastolic dysfunction, with signs of ischemia, with mitral regurgitation, or with systolic dysfunction. And in hypertrophic cardiomyopathy, systolic dysfunction that's significant is actually defined as LVEF less than 50% rather than less than 40%, which we're used to using in the average heart failure patient. There are different locations where the thickness can occur. And so this is kind of a nice image, I think, to describe where the thickness is, but then also what the cavity shape is, because sometimes it's sort of hard to figure out what's thick when you're looking at an echo, but these two things in combination, I think, are good for pattern recognition. So the reverse curve is most associated with genetic abnormalities, and that's when the mid wall of the septum is thick. The shape of the LV cavity will then be like a crescent. There's also the neutral phenotype, in which you'll just kind of have a neutral shape to the LV cavity, but the septum is typically what's thickened. The most common form that we see is when the basal septum is actually thickened, and we call that sigmoid septal hypertrophy. You'll have an ovoid shape to the LV cavity with that. And then apical hypertrophy, which I think is getting picked up more and more often as people are becoming more and more aware of the disease, and our contrast agent use goes up. And that's the where the apex is thick and it looks like an ace of spades. That's the way the cavity shape is, and that's typically how it's picked up. Like I mentioned, there are some folks that have this obstructive LVOT obstruction, in which that it can be present in 2/3 of patients that are diagnosed with hypertrophic cardiomyopathy. And that's defined by having a gradient across your LV outflow tract that's greater than 30 millimeters of mercury. There are two forms of obstructive disease. So there's the type that's present at rest, which we can pick up on a resting echo, and that's in about 1/3 of people with this condition. And then another 1/3 will be picked up when we provoke them, and that's typically done through exercise testing. And typically what we see on an echocardiogram might be evidence of systolic anterior motion of the mitral valve. So this picture is maybe not the best picture to see it super easily, but you can see some portion of the mitral valve is heading towards the septum when the mitral valve is closed, which would mean that we're in systole. And that can be a sign that we're dealing with obstructive hypertrophic cardiomyopathy. And sometimes the terms that are used in echo reports are systolic anterior motion of the mitral valve. And these patients will typically have a harsh mid-systolic murmur that's worse with Valsalva and improved with squatting. So it's sort of the test question for this murmur. In this particular patient population, it is not recommended to do dobutamine stress echoes to assess for provocable gradients, because dobutamine can make the LV hyperdynamic. And in patients with normal hearts, we can actually induce LVOT obstructions. So typically it's exercise, and in centers where we're seeing lots of hypertrophic cardiomyopathy patients, the staff is typically used to modifying these exercise protocols. So even if people can just go on the treadmill, flat ground in only a few minutes, we should be able to accommodate those, but obviously it'd be a non-standard stress test. The symptoms associated with this condition can also be quite variable. So people can have fatigue, they can describe exertional dyspnea, and that exertional dyspnea can either be due to a LVOT obstruction or from the diastolic dysfunction that we see. Some people will describe chest pain, and usually chest pain with exertion, or palpitations, because arrhythmias are quite common in this condition. And then sometimes if the LVOT obstruction is quite significant, or if people are having significant arrhythmias, they'll present with presyncope or syncope. So in follow-up to case one, this particular patient ended up being referred to cardiology clinic. And on my review, I thought the diagnosis was likely hypertrophic cardiomyopathy. So what's involved in the initial workup when we suspect someone has hypertrophic cardiomyopathy? So first, we have to recognize that hypertrophic cardiomyopathy has some mimics. And so the most common ones would be having an athlete's heart. Hypertension can result in LV hypertrophy, and then aortic stenosis, because our hearts are working against sort of high gradients or obstructions to flow. And then another more and more common condition that can be a mimic for hypertrophic cardiomyopathy is amyloidosis. And then there are a number of other genetic conditions that can result in LVH that's not necessarily hypertrophic cardiomyopathy, but reflective of another condition. So the initial workup of hypertrophic cardiomyopathy partly is to distinguish this condition from the mimics. So it's recommended that everyone gets EKG, some form of imaging, and consideration for genetic testing. The EKG will be abnormal in 70 to 95% of people who have hypertrophic cardiomyopathy. And you'll be looking for things like pseudo Q waves, LVH, ST and T wave abnormalities. Those can be seen commonly in this condition, whereas opposed to amyloidosis, where you would see low voltages on an EKG. The imaging modality of choice is an echocardiogram, but if you have poor imaging windows, a cardiac MRI would be recommended. If you don't have access to a cardiac MRI, sometimes CT can be used, and that's endorsed in the guideline, though that's not a modality I reach for very commonly for these patients. And then genetic testing is recommended because it can have implications for family screening. The results of the genetic testing itself do not have any sort of treatment changes for patients as of yet. So if you have someone that ends up being phenotype positive for hypertrophic cardiomyopathy, meaning you pick up that LVH and they've got some EKG abnormalities, or they've got genetic testing that's positive that fits with this diagnosis, then it's recommended that they have a baseline evaluation for sudden death. And we'll talk about that a little bit later because risk of sudden death is a bit higher in this population. And then stress testing, either to assess for those provocable gradients if you didn't see a resting gradient, or to get a sense of what the functional status of this patient is. And then every 1 or 2 years, or with any change in symptoms, we should have a clinical assessment, an echocardiogram, and consideration of a Holter monitor, because arrhythmias are also more common in this patient population. And then every 3 to 5 years, a cardiac MRI should be considered. And that's partially because of the sudden death risk stratification, which I'm going to talk about a little bit later in this talk. So moving on to a second case, it's mostly a question for the audience that I'm not expecting you to answer, but just to think about. So I've got a 31-year-old patient with a new diagnosis of apical HCM and a strong family history of this condition. In which of these scenarios would this patient receive an ICD? So if they've had an unexplained syncopal event at age 15, if in the family history he notes that his father experienced sudden death and also has an ICD, if he reports an unexplained syncopal event that occurred 3 months ago, if in the family history he notes that his paternal grandmother had a sudden cardiac death event, or you note that the LV wall thickness is 27 millimeters on echo. So one of our important jobs when we see these patients is to always screen them for sudden death. Not every single patient with this condition has an elevated risk of sudden death, but we do know that there is a subset that do. And so this is from the most recent guidelines, which has a little bit of an algorithm to figure out who should be considered for an ICD. So essentially someone comes in with a prior history of sudden death, with a history of VT or VF, then an ICD is indicated, which would be standard even if they did not have this particular condition. Then there are a set of major criteria for pediatric patients. If they have any one of these, ICD is considered. In adult patients, it's not quite as straightforward, but which we can talk about, which I will talk about also with this set of slides. But the risk factors are having a family history of sudden cardiac death, having massive LVH, having unexplained syncope, being found to have an apical aneurysm or an LVEF less than 50%. And just to sort of further describe those, so a family history of sudden cardiac death would be having a history in a first-degree family member. Massive LVH would be having a wall thickness greater than 30 millimeters. Unexplained syncope would be having a syncopal event within the last 6 months, with more remote events, especially those that are more than 5 years out, not really conferring much excess risk to the patients. And then other things that we're looking for would be non-sustained VT. Another place where management for children versus adults will differ. So if that's seen in monitors in patients that are aged less than 16, then an ICD is considered reasonable. But in adults, the prognostic information related to finding NSVT on monitors is really related to the increased frequency of NSVT or having longer durations of NSVT. And then the last thing we're looking for is having late gadolinium enhancement on a cardiac MRI. And if that's seen, we're looking for a quantification of the percentage of LGE, and we're looking for numbers that are like 15 to 20% or greater. If you're seeing that on a cardiac MRI that you obtain, an ICD should be considered. And if you're not meeting any of these criteria, then an ICD is not indicated. There's also another tool that we have, which is the European Society of Cardiology has a risk calculator that was developed that's based on slightly different criteria and uses some echo parameters like the LA size. And you can input that in all these numbers into a risk calculator that is available in app form now in multiple locations or online. And if you pop out a risk that's greater than 6%, an ICD is indicated. And then if the risk is less than 4%, ICD is not indicated. And then 4 to 6% is sort of this borderline individualized decision-making criteria. So typically I'm using these traditional risk factors on the left side of the screen, which is endorsed by the ACC AHA, and then also this calculator on the right side of the screen, which is also now made it into the 2020 guidelines. All right, so going back to our questions, so the scenarios in which this patient should receive an ICD would be if in the family history, he notes that his father, who would be a first-degree family member, has experienced sudden cardiac death, and then that he had reported an unexplained syncopal event 3 months ago, because that would be within the last 6 months, and we know that confers increased risk. So after we've sort of done our screening studies, what's actually involved in the management of hypertrophic cardiomyopathy? So another case of a woman that I was referred, so 47-year-old woman who was referred with a new diagnosis of hypertrophic cardiomyopathy, and she also reported having significant exertional dyspnea. She has no family history of hypertrophic cardiomyopathy or of sudden death in her family. And then her echocardiogram shows a high baseline LVOT gradient, which was noted to be at least 50 millimeters of mercury. So she completed an exercise treadmill test as part of her screening, and her exercise time on a standard Bruce protocol was 3 minutes, which we all know is not that great. So the goal of treatment in this patient population is to improve symptoms and then to minimize risk of sudden cardiac death, thromboembolism, and stroke. So the initial assessment, if we find LVOT obstructions, which again are pretty common in this patient population, the management can be either pharmacologic or invasive. So step one is typically to discontinue drugs that can worsen the obstruction. And those are things like diuretics, digoxin, any stimulants, and then any vasodilators. The diuretics are the ones that I think most commonly come in because a lot of these folks have other cardiovascular conditions that are being treated, such as hypertension. And we're often reaching for diuretics relatively early when we're treating our hypertensive patients. But the issue is that it can sort of make the patient dehydrated or make that LV cavity smaller, which can then worsen that LVOT obstruction. And then in patients who are hypotensive, the number one management for this would be to give them fluids to really plump up that LV and make sure that the LVOT obstruction is not causing issues. And then if you need to reach for a pressor, something like phenylephrine, which is mostly a peripheral vasoconstrictor, would be preferable versus something that's inotropic, that like a norepinephrine, which may make that LVOT obstruction worse. In terms of specific therapies to manage the LVOT obstruction, the mainstay of therapy are non-vasodilating beta blockers. So metoprolol is what's being reached for most of these patients. As alternative therapies, non-dihydropyridine calcium channel blockers can be considered, and then disopyramide, which is usually used as an additive agent to one of the either a beta blocker or a calcium channel blocker. The downside to disopyramide is that you get those anticholinergic side effects, so you have to monitor patients for that. And then for patients who are symptomatic despite medical therapy, invasive therapies can be considered. And those are typically for patients who still have LVOT obstruction with gradient greater than 50 millimeter when you're doing repeat imaging. There are two options for invasive management. So surgical myectomy, which has a bit more durable data in terms of long-term follow-up for patients, and then alcohol septal ablations. So the surgical myectomy, it is done through a median sternotomy. So this is a major cardiac surgery. The surgeons basically can go through the aortic valve and then reach any of the myocardium that is very proximal in the septum. So this is a little picture of typically what's done in a myectomy. There are some specialized centers that can do myectomies for apical hypertrophy, and they go through an apical approach. But that's not necessarily the most common version of this. And then there's data for surgical myectomy that the best outcomes are from centers that are doing this the most often. So those would be places like the Mayo Clinic or Cleveland Clinic, which are probably the two most high volume centers for this. So having some sort of surgical expertise does make a difference in terms of how well these patients do post-surgery. And then the other option that we have available to us is alcohol septal ablation. And this is a cath lab procedure. The operators will find one of the septal perforators off of the LAD. They will try to figure out which one is actually feeding the bulk of the myocardium. And then they inject some alcohol and try to kill off that vessel. Sometimes these patients may need more than one procedure to get sort of complete resolution of that excess tissue. And then this approach does not have as great long-term data for it as the surgical myectomy in terms of how durable these results are, but might be preferable for patients who would be high risk for an open heart surgery or that are older or for their own patient preferences. And then expertise in this particular procedure is getting more and more common, especially as people are learning how to do these trans mitral valve replacement procedures, because oftentimes people are receiving alcohol septal ablations for those procedures. So I think general operator experience with this procedure will be higher compared to a surgical operator's experience with myectomy. So this actually may end up being more accessible for more patients. There are also a couple of novel therapies that are on the horizon that I must mention. So one that is slotted to be approved in early 2022 is mavacamten. So this is a first-in-class selective inhibitor of myosin. And so what essentially is happening in hypertrophic cardiomyopathy is that you have more actin-myosin cross bridges than you would in a normal sarcomere. And what mavacamten does, it is a small molecule that inhibits those cross bridges. And so it sort of relieves that hypercontractility that can occur in this condition. In clinical trials, we've got these results from Explorer HCM, which were published in Lancet in 2020. And essentially they randomized about 250 patients to either mavacamten or to placebo. And their primary endpoint in this study was looking at parameters that can be assessed off of a CPET. And they found that patients who were receiving mavacamten had greater improvement in some CPET parameters compared to folks that were getting the standard of care of beta blocker, verapamil medical therapy. And then when they looked at specifically all of the gradients, the mavacamten group in these bottom section is in blue. And on therapy, the mavacamten group had greater reductions in the resting LVOT gradients, the LVOT gradients that are induced by Valsalva, and then in the exercise LVOT gradients compared to the placebo group. Now there's also a second myosin inhibitor that will be in clinical trial soon. I think some centers are already enrolling in a phase 3 clinical trial, and that's aficamten, which was previously known as CK-274. They just presented the results of their phase 2 clinical trial at HSFA. And so this is a slide from their website because I don't think that this particular study has been published yet. But essentially they randomized just a few number of patients, I think in total about 40 patients, to either the placebo group or to 2 different dosing strategies for this aficamten. And they found in both dosing strategies that there was a reduction in the resting LVOT gradient. So now they're going to enroll in a larger clinical trial. And I think a number of centers in the Pacific Northwest will be participating in this trial, including our center, but I think also OHSU, in case you guys have patients that are close to either one of these that you think may benefit from these, from being enrolled and potentially receiving this therapy. AFib is an issue for hypertrophic cardiomyopathy. So the gist of it is that AFib is typically not well tolerated in this patient population. And then also don't calculate a CHA2DS2-VASc, just anticoagulate all of these folks. And that's because there was a study that was done that showed that basically the CHA2DS2-VASc score in this population is not a great risk estimator. And that in general, all of these patients are sort of high risk for thromboembolism and stroke. So in this slide, we see that the low risk group with having a CHA2DS2-VASc of 0 is in green, the high risk group having a CHA2DS2-VASc greater than 2 is in yellow, and the risk is very similar for having some sort of thromboembolic event in this population. This is a busy slide. The guideline version of this slide is even busier, so I tried to simplify this, but essentially systolic heart failure starts as soon as the LVEF drops less than 50%, and then otherwise we're following similar things to what we see in the heart failure guidelines. They should be started, these patients should be started on GDMT. You should discontinue any of the negative inotropes, so that would be the calcium channel blockers and the disopyramide, and then ICD should be considered as soon as LVEF drops less than 50%. Patients should be reevaluated after they've been started on GDMT. If they're class 2 to 3 and they have a left bundle branch block, you should be considering CRT therapy in them. If they're still class 2 to 3, in general, we should be evaluating these people for heart transplant or advanced therapies. And then the other kind of patient group that should be evaluated for heart transplant and advanced therapies would be if you have an LVEF less than 50% and you're having issues with recurrent arrhythmias. And then some sort of lifestyle considerations that are important to discuss with patients. So mild to moderate intensity exercise is considered safe in these patient population and should be encouraged. Previously, it was only mild exercise. So there's been data since the prior guidelines to the 2020 guidelines that moderate intensity exercise is also safe. And then patients should be evaluated and there should be a discussion about any participation in competitive sports. Same thing with pregnancy. Pregnancy is generally safe in people who are clinically stable. There are some risks to the fetus with being on beta blocker therapy, like having a smaller size of the baby when they're born or having some intrauterine growth restrictions. So those risks should be discussed with patients, but generally pregnancy is very safe in this population. And then in terms of moderate or high intensity exercise, that should also be a discussion with the patient reviewing risks and benefits of that, but it's not absolutely contraindicated, which is a change from the prior guidelines. And then ICD placement just for the sole purpose of sports participation is a class 3 and should not be done. Shared decision-making has a more prominent feature in this most recent set of guidelines. And a lot of folks that are seeing hypertrophic cardiomyopathy patients in high volume were doing this anyways prior to the guidelines sort of making this an emphasis, but this should be done by all of us. So this means having a discussion which includes disclosure of risk and benefits. It's talking about the anticipated outcomes of all the different options that you're presenting, and then taking into account the goals and concerns of the patient or of the family if the patient is a minor. And these shared discussions should be applied to considering genetic testing for the sudden death risk assessment and consideration of ICD, for participation in high intensity sports or in competitive sports, and then for that decision about medical management versus invasive therapies for LVOT obstructions. And then treatment of this condition is a team-based sport and usually involves a lot of discussion and collaboration between multiple different centers. So there are the folks who are out in the community who are seeing these patients who often start the initial testing or are responsible for taking on that mantle for doing the surveillance testing. They're often initially starting the treatments and monitoring patients, and they're usually the first line of defense when there's been rapid changes. Then there are these HCM centers of excellence, which can provide some maybe specialized testing like genetic testing and counseling or consideration of some of these advanced treatments, or sometimes arrhythmia management can be difficult in this population, and having access to certain EPs that see this in high volume can be quite helpful in this population. And then we have these comprehensive hypertrophic cardiomyopathy centers, so something like a Mayo Clinic, which can manage these complex surgical procedures or complex ablations for patients with really bad recurrent arrhythmias. And then in general, having some sort of awareness of who's able to do heart failure transplant and advanced therapies in your region is helpful, because as soon as that LVEF drops below 50%, that should be on your radar as something that you're thinking about in this patient population. So just to follow up in the case that I presented, this patient was started on metoprolol. She's been up titrated, but is still symptomatic. So we've been discussing whether or not a myectomy is in her near future. We discussed that low and moderate intensity exercises were safe, and she's made a plan for an exercise routine based on that. So in summary, hypertrophic cardiomyopathy is a sarcomere-related genetic disorder, and it might be more common than we think. To diagnose hypertrophic cardiomyopathy, the LV maximal wall thickness should be greater than 15 millimeters, and the ventricle should be not dilated. And we should make some effort to look for mimics, especially common mimics like aortic stenosis or amyloid, which may have their own treatments. The initial workup is focused on excluding those mimics, defining the symptoms, and then assessing risk of sudden death. And then treatment is really based on improving symptoms and then reducing risks of any of those complications like stroke, thromboembolism, or refractory heart failure. And then shared decision-making is really important with these patients, especially for things like ICD, which for some folks can be very anxiety-inducing or life-changing to have a device like that in place. And finally, this approach to care should really be team-based, and that sometimes means that it's going to be multi-center with a lot of cross-collaboration. So with that, I'd like to say thank you for having me today. If you have any questions, I'm more than happy to answer them. And then a couple of resources that I think are helpful. Both the ACC and AHA have guideline apps to help you navigate this, including those calculators for sudden death risk stratification. And then sometimes the guideline documents are really dense. The ACC has these nice summary slides, which are like the top 10 takeaways plus all the figures pulled out. And then the AHA has started doing these clinical summary slides where they have a group of clinicians making their own versions of these slides. So for example, this slide here is from the AHA clinical summary slide. So there's some good resources out there for you.
Thank you so much, Dr. Savla, for that excellent review of HCM and for telling us how to find the most succinct information. That's always helpful. It's exciting to hear about, all the new medications in this space and the new trials. So it'll be great to see what happens even in the next few years. Just want to open up the floor to any questions from our panelists or from our audience. If anyone has any questions for Dr. Savla.
Katie, can I ask a question, or do you have any other questions that are out there?
No, go ahead.
Great. That was awesome, Janie. Thank you so much for the talk. What are your thoughts on ECG screening, kind of in the younger population looking for this condition? I know it's a kind of a controversial topic in the United States, just given the heterogeneity of our population. But what's been your experience? What are your thoughts on that?
I think depending on who you talk to, you'll get a different answer on this question. So where I trained, I worked with Ben Levine, who's sort of not in favor of routine ECG screening. And then currently I'm working with Dave Owens, and that group sort of favors ECG screening. So I think it depends on your sense of where the value is in cares in some sense of it. So it's like, well, is the cost trade-off to preventing one death there for ECG screening? In general, it seems that these conditions are still ultimately pretty rare, and ECG screening has largely been determined by state legislatures. And it seems to me reasonable that people would get an EKG, and especially if they have any sort of family history of undefined cardiac diseases, with follow-up echo if there's some sort of abnormality. But I don't know if I have a great opinion on whether we should be like routinely screening 14-year-olds for participation in track and field, for example.
Yeah, it kind of comes back to like, what are you going to do with the data? And it then tends to oftentimes lead to more downstream testing and worry. And what you said actually makes a lot of sense, just focusing on the clinical features, family history, and then working things up from there. One of the things that we see a lot of here in Wenatchee and North Central Washington are maybe a little bit older patients than the ones you described. They come in with heart failure symptoms, maybe atrial fibrillation. We do an echo and they've got kind of moderate LVH, and it's just not totally clear what's going on. Could they have HCM? I mean, their EKG oftentimes suggests hypertensive heart disease, but there's a lot of overlap there. So I guess the question I have for you is, what's your threshold to jump to a cardiac MRI in patients like this? And you know, how do you use those results to kind of help guide how you treat them, you know, kind of long term?
Yeah, I think this is a great question because this comes up quite frequently, even amongst my partners over here. So my threshold to do a cardiac MRI has gotten lower and lower over time because I have picked up hypertrophic cardiomyopathy in some of these older patients that get referred. And I can think of a specific example of an 84-year-old woman who's got very variable hypertension with blood pressures that sometimes in clinic would be in the 200s, who, you know, obviously would have a very good explainer for LVH, but when I did her cardiac MRI, her LGE pattern just didn't fit with hypertensive heart disease. And the reason I was glad I screened her is because she's got 4 kids, and one of them has now been picked up to also have LVH. So I think when you hear, you know, obviously this is maybe a little bit of working off of anecdotal experience, but I think having imaging, EKG, and then genetic testing as sort of your baseline set of factors to help distinguish whether you're dealing with HCM or a mimic is really helpful in this patient population. And sometimes that means that your imaging test is not only going to be an echo, but also a cardiac MRI.
And is your sense that apical HCM is a bit lower risk from a sudden cardiac death perspective, obviously in the absence of, you know, apical aneurysms and things, or is it kind of, should we be treating the apical HCMs kind of similar to the more classic, you know, obstructive phenotype?
Yeah, my experience with apical HCMs are that they're not particularly symptomatic. So they don't get a lot of this dyspnea on exertion or chest pain or some of these symptoms, but they do seem to sometimes have those sudden death risk factors. So from a sudden death evaluation, I do all the same stuff, but knowing that these are typically stable patients from a symptom perspective. So they're not necessarily getting beta blockers and those sorts of things, but I do still evaluate them for sudden death the same way, which is like Holter monitoring, cardiac MRI every 3 to 5 years. I was previously doing 5 years, but the guidelines are now saying 3 to 5 years on that. And then making sure that like no other family members have popped up, or sometimes like when you first ask the question, people will be like, oh, I don't have a family history of that. And then they start asking around. And so it's visit 2 or 3 that you actually get a legit family history off of people after they started calling some family members.
Thank you. That was awesome.
I do just have one quick question from the audience. And I think it relates to maybe one of the case studies that you presented earlier, talking about the treadmill test. And they were wondering about the risk of doing exercise treadmill tests when it's used earlier on in the diagnostic testing, specifically in regards to potentially inducing, you know, life-threatening arrhythmias.
Yeah, I think this is a very good question because these treadmill tests are definitely a little bit higher risk than other routine treadmill tests that you're getting for other indications. So at the University of Washington, for example, we make sure that these treadmill tests are being done at the main medical center as opposed to some of our satellite sites where this is being done. So some of this is based on the comfort of everyone in the care team who are doing these stress tests, knowing that you might see some ventricular arrhythmia. So if you're at a remote site, you may not want to necessarily be doing these treadmill tests, but some of these bigger centers, like both in Seattle and in Spokane, may have a bit more comfort. And if you can convince the patient that they're willing to travel for one visit and just try to get everything done at that visit, then I think that would be the safest plan moving forward if there's discomfort in doing this treadmill test locally because of that risk of arrhythmia. So I think this is a legit concern. It's there, and everyone on the team has to be comfortable doing the stress test.
Great. Thank you so much for your talk today, and we appreciate it. We're gonna just quickly transition into just an update for everybody about what's been going on with the ACC this last year and a half or so. Dr. Nayak's here as well to kind of give us some updates on what's been going on. I do want to share with you some upcoming events. Let me just share my screen here so you can see the dates of these. So coming up pretty quickly is the legislative conference, typically held in Washington, D.C., live in person, October 3rd through the 5th. This year, again, due to COVID, will be virtual. But in some aspects, that's probably beneficial, can save a lot of you a trip across the country, but still gives you some opportunity to learn about advocacy, networking with members of the legislature. There's a day where you learn about the current health policy topics that are affecting our cardiovascular patients and what some of the current issues are that we want to talk with our members of Congress with. And then on the 5th, there's some actual virtual visits with staff members in Congress. So it's a really great opportunity if you have any interest in learning about advocacy. And I've had the opportunity to attend in the past. In 2019, Dr. Nayak and a few of us went out to DC, and we had the opportunity to talk to a few different people about the Tobacco 21 Act. We talked about the increasing access to cardiac rehab. So that's the one that's allowing APPs to supervise and order cardiac rehab. So that was a great opportunity. So if you are available to check that out this October, definitely do that virtually, and hopefully next year we'll be doing it in person again. And then Dr. Nayak, would you mind just sharing with us a little bit about the upcoming Washington ACC chapter meeting in November?
Yeah, thanks, Katie. I think this is going to be another great meeting. And by the way, kudos to you and the team and Liana for putting together an amazing meeting so far today. And I think it's going to be hard to top what we've done already today, but I think that the chapter meeting is going to have a lot of other great educational content. There's not going to be much overlap with what we've done today. So even more great education. And again, it's going to be virtual November 6th and 7th in the morning on both of those days. And then hopefully by next year, we can maybe start to see some light at the end of the tunnel and maybe start to do more live events. But appreciate everybody coming on today. And if you're not an ACC member, please join and send myself or Katie an email, and we can give you information on how to join. And for CVT members, there's pretty significant discounts. And if I remember right, it's free the first year, Katie, is that right? And then there's a ton of really great things that come up through the ACC for everybody.
Yeah, there's typically a code that they share every year to allow new members to join for free. So it's a really great opportunity. The code for last year has expired and we're waiting on a new one, but I'll be sure to share that with everybody as soon as we get that, because it's a great opportunity to get your first year free and then access all the great benefits that we have for membership. So we'll make sure and keep everybody posted on that. I'm going to go ahead and stop my screen share here. And I think that I will go ahead and segue into our next session. So our final event for this symposium, I'm really excited about this. We're having a couple special guests with us today to talk about telemedicine in Washington State. So I just want to briefly introduce each of our panelists who have joined us. I first would like to welcome Congresswoman Kim Schreier. Dr. Schreier, hi, hello. She represents Washington's 8th Congressional District, including parts of King, Pierce, Kittitas, Chelan, and Douglas counties. Prior to her election in Congress, Dr. Schreier worked as a pediatrician in Western Washington. So welcome, Dr. Schreier. Thank you so much for joining us this morning.
Thank you. Wonderful to see you.
Thank you. And I'm also joined by Joelle Fathi. Joelle is an adult primary and acute care nurse practitioner. She has over 20 years of patient care experience at the local, national level, advocating in telehealth and tobacco control. also served as the program director of telehealth clinics and a member of the Washington State Telehealth Collaborative. So I want to welcome Joelle with us today as well.
Good morning. Thanks for the invite.
So great to see you. And of course, any of our other speakers that were on today, I'd welcome you to join us and chime in if you have something you'd like to offer up for our discussion of telemedicine. It'd be great to have you guys as well. So I wanted to start by asking the panelists to share a little bit about your background specifically with telemedicine. I was hoping to start with Congresswoman Schreier, if we can. I'd just love for you to tell us a little bit more about yourself, your personal experience as a pediatrician, and how that influenced you to advocate for telehealth in Washington and on the national level.
Well, thank you, Katie. And it's great to be here. You know, I was a pediatrician for 20 years and never used telemedicine myself. I think just because of the dates and the circumstances didn't arise. But, you know, when the pandemic hit, I think it just became plainly obvious to all of us that people needed to access care, but the very people who needed the most care were also the most fragile and the most susceptible to devastating consequences of COVID. And so it became just really urgent to rapidly expand telehealth from, you know, the way we used to think of it, which was a specialist who could join a primary care doc in the office virtually, to something where people could access this from their own homes. And so it really just came from, you know, I guess kind of just a common sense understanding, maybe a little bit better because I'm a doc myself, but it became very clear how necessary this was.
Yeah, absolutely. I think we have felt that as well here in North Central Washington. We have done some telemedicine of sorts over the last 5 years with our outreach clinic in OMAC. And we've really felt the struggles of connecting with those patients in clinic face to face. And that was really highlighted when we were kind of pushed into the more virtual care space over the last year. I was going to invite Dr. Nayak to talk a little bit more about, you know, our experience with telemedicine in Wenatchee, North Central Washington, and his background with starting kind of telemedicine for our clinic as well.
Yeah, no, I think that, you know, Dr. Schreier kind of hit the nail on the head that the pandemic kind of brought everything to the fore, but in places where there's less access, especially, you know, in these rural areas, we start to kind of run into problems related to just getting our patients in, especially in the specialty setting. You know, if they're 2 hours away, coming to Wenatchee for a 15-minute visit to discuss their cholesterol, or if they're really sick, you know, having to get an EKG quickly can sometimes be challenging. But if they could go to their local clinic and then patch into us in Wenatchee, we could probably save them a lot of time, a lot of money with gas, and obviously, if it's more acute, we can get an answer to them much quicker. And so, you know, in 2015, we started to play around with that. And, you know, I see Joel on here as well, you know, as far as just getting better access to care in our remote outreach clinics. And it really was, it's a little clunky. They have to come to our clinic in OMAC. They have to get checked in like a regular visit. And then, you know, we kind of see them. It's better than driving 2 hours, but I think the game changer has been, like Dr. Schreier said, seeing the patients at home where they are. And I've been kind of humbled at how much I learned just seeing them in their, you know, regular setting. Half the time, the spouse is on the phone or on the couch with them and can give you some body language that helps you kind of gauge what's going on. And then, and I think, I'm sure we'll talk about this a little bit. You know, there's a lot of patients where it's, you know, you're just kind of forced to do the audio only visits because they just don't have the resources. And so either you're telling them to drive to Walmart or to drive to the clinic parking lot and patch into the Wi-Fi, or they don't even have that capability. They don't have a computer or a smartphone, and you're really kind of just forced to call them. And so I think it's brought out a lot of the different issues related to the social determinants of health that we spoke about earlier in the meeting. So our experience has been very vast and varied, and the pandemic has just kind of brought to the forefront that we need to get better at how we use telemedicine.
Joelle, I wanted to just open it up to you as well, just to tell us a little bit about your background with telemedicine. I think when we last talked, you had mentioned some background in using it for post-surgical patients and also for tobacco cessation.
Yeah, thanks. You know, I think so telemedicine is something that's really been in the forefront of my mind for well over a decade. But it really kind of stems back to where I come from. I was born and raised in Montana. I had a very seriously ill mother who had to travel either west or east a considerable distance to get the healthcare that she needed in the, you know, really the 1970s and 80s and well into the 90s. And so it really kind of sears deep for me in terms of understanding what that meant for us as a family with no money and health issues in a family. Almost 20 years ago, I ran the outreach clinics for solid organ transplant clinic in Montana, Alaska, and Idaho. And every 6 weeks, the surgical team and myself, social workers, surgeon, nephrologist, and myself would go out to these outreach clinics. We would see people who would come from miles around to see us in Alaska, for example. They would drive long distances just to see us there. Hardship, again, very poor, you know, people from poor communities who have absolutely suffered from the social determinants of health. And even that was a hardship when we went to their state. But it was expensive, right? We were putting medical and surgical teams on airplanes around the year in dangerous weather to run outreach clinics. And but then we would transplant them and send them back to these communities, which is important for them as soon as possible. But I'm licensed in all these states because I was managing these people. And at the time we didn't have audio video. I was managing people probably, you know, by definition, illegally over the phone, because there's a lot to manage to keep these people safe and make sure that they don't reject their organs and or understand when they need to expeditiously get back to our facility to get them the care they need if things go wrong. I worked in the Cancer Institute, a large health institution locally, and that's where I ran tele-lung, tele-tobacco clinics for a thoracic oncology, thoracic surgery group, and also tele-lung screening. And so really kind of across that continuum of preventive care, management of people in workup for thoracic and GI cancers, and post-surgical follow-up, which again is really important. If, you know, thinking about lung cancer alone, 90% of the people who develop lung cancer have been former or are current smokers. These people, by definition, have suffered social determinants of health. They're chronically ill and they are impoverished. And many of them are living in our rural areas in Washington. So this was long before telehealth hit. And so, you know, even for us, there was a struggle on the medical end of not only getting our digital equipment set up, but how do we get that connectivity out there? So I'm touching on a lot of different topics in this space. We have a huge rural population in Washington State and beyond. And we're well on our way, but we need, desperately need people like Dr. and Representative Schreier on this call to really kind of pave the way to get what we need and take telehealth to the next step. It's an exciting time, but we can't let off the gas pedal now.
Yeah, I agree with you that the momentum over the last year has been really important. We've seen how quickly an organization can develop a telemedicine program, which we originally thought, or maybe people thought in the past, would take a significant amount of infrastructure, and we were able to do it quite quickly. But you did touch on a few of the things that I think segue into my next question was, you know, we've talked about the benefits to telemedicine, which are quite obvious in providing care to people who otherwise may not get it, allowing people to have care where they are, where their support systems are, and to address some of those social determinants in people that may not have time or access to transportation or other things that prevent them from traveling to clinics or specialty clinics. But over the last year and a half, we've also seen a lot of barriers to telemedicine uncovered and highlighted, just in the ability to get people connected to a connected device or in an area where they have broadband or things like that. So I kind of wanted to talk a little bit more on thoughts about what are the barriers currently to telemedicine and how we may overcome some of these as we move forward.
I always have a lot to say. I want to give anyone else on the call an opportunity to weigh in before I launch that one.
I'm happy to talk about some of the things that we can do from a policy standpoint, and I'll be concise so that Joelle can expound. But of course, one of the biggest barriers is just having access to high-speed internet, and that is why in the bipartisan infrastructure plan that we're going to pass very shortly, there is $65 billion in there for building out rural broadband, for connecting people who are in urban areas where they have access but can't afford it, but also for teaching people how to use it, because there's getting connected and then there's figuring out how to use the device and use the technology. So that's one, and another is, in the meantime, when not everybody has broadband, being able to do telemedicine audio only is a big help. But the other big help is something that they're piloting at King County libraries, also in my district. And I don't know if they're doing it locally for you, but King County Library System, in several of their libraries, they're taking one room and basically, like covering the windows, making it private, having broadband, and people can coordinate an appointment with their specialist or their physician and with the library, block out time and go to their local library and have that visit using telemedicine, because it is so much more effective to have the visual with the audio. And if I could just comment briefly on Dr. Nayak's comment about the benefits of seeing patients in their own homes, whether that's a child who's more at ease and you can see how they are functioning, kind of their social emotional development in their home. I hear about that from my pediatrician friends. For me, it's been a personal benefit as my parents are aging and I'm able to attend their appointments remotely, and how much more effective those appointments become. So anyway, there's some benefits and there are some ways of overcoming them.
That's fantastic to hear about the money and the support that's coming for broadband. And I'm so glad you touched on the importance of teaching patients how to use the broadband. We cannot just provide it to them and assume that they will hit the ground running with it. So we got to set them up for success. So that's fantastic. Joelle, I'll go ahead and let you speak as well.
Yeah, sure. So kind of building on what Representative Schreier had to say, it's fascinating that 25% of King County residents are, technically it's an urban area, and yet 25% of them don't have the access or the speed to support an audio video conferencing call. And so that's pretty sobering that, we often think of telehealth in that sort of rural space, and we know that there's a massive digital divide rurally, but we see it in the urban settings too. And both populations of people could really benefit from telehealth. And really kind of thinking more broadly about how we roll this out to people. Some colleagues of mine at University of Chicago recently did some research looking at various populations across the health system. And the bottom line is there definitely is a sort of line that we can draw in terms of adults and older adults who feel who are digitally literate. And really kind of that age cutoff is 50. This is what this research definitely shows. So, and that makes sense, right? If you think about those of us on this call who are 50 and older, we've seen technology really evolve from nothing to something. And so people not only don't have the access, but they, even if they have the access, they really truly feel intimidated and they just don't know how to use the devices. So it's really great that we're starting to have the discussions around, and I know some health systems are starting to look at or employ people to, help desks that are just designed to help people get up and running and confident and competent at utilizing the technology and easing the path in terms of patient portals, being able to create that connectivity with ease so that there's less troubleshooting that needs to happen in order to use these devices. But I think knowing the population who needs that can help us target those people.
I had a question.
I will also,
go ahead. Go ahead. Sorry.
I was just going to say, it's really important that we think about some of the other issues around telehealth that are very real, which is, when we start launching into the telehealth space, and this is some of the stuff that we're looking at with the, Representative Marcus Riccelli, who's really currently sponsoring the House bill, I think it's 1156, looking at advancing telehealth in various ways, including language around establishing an established provider in that telehealth visit. And so while we need to break down certain barriers to ease that healthcare, I think it's really important to remember that we want a safe and responsible platform, including providers who are engaged with the patient's electronic health record. That they, we do have to iron out whether or not those patients should have an established relationship, at least with the health system that a provider is seeing them for. So there are some challenges that we're being faced with in terms of writing policy and enacting it. And I'd be curious if Dr. and Representative Schreier have some thoughts about that from those lenses.
I'd be happy to comment. They are already studying some of the safety issues. There are all what I've seen and what we've all seen, whether it's pandemic unemployment or whatever there's always scammers, right? There's always somebody who's willing to take advantage of a system. And so if you design a robust telemedicine system, will there be an incentive for some bad actors to move all of their patients to virtual so they can squeeze in more patients per day and have pay parity, and so we also need to watch quality of care, how that changes. We need to watch whether, how many missed diagnoses there are because somebody doesn't come in and say you missed the skin cancer on the side of their neck. How many teens come in, you miss their scoliosis because they weren't there in person. And so striking that right balance between the number of in-person visits and the number of virtual visits, and whether you have an existing relationship with the doctor or with the health system. I think these are very nuanced issues that I think we're going to kind of have to work out over time. And I don't think that Congress is who should be making that decision. Certainly not based on my experiences in Congress. I think that should fall to the academies, and the associations like yours to say, here's what's a reasonable amount. We can do EKGs by telemedicine. We can check O2 sats. We can maybe look at JVD, but we maybe can't see swelling of the ankles. Whatever it is, how far can telemedicine reach safely?
Yeah, I think these are actually just piggybacking on that a little bit. I'd be curious both what Dr. Schreier and Joelle think as far as just the way that telemedicine is deployed across state lines. I think that's become a bit controversial as well. I mean, on the one hand, you have rural areas or urban areas with really limited access to specialty care, and maybe there's a specialist sitting in, New York City that can help right away, versus the fact that it's really obvious that you do want to have an established clinical rapport with whoever you're doing a telemedicine video visit with. How do you strike that balance? I mean, from a legislative perspective, I imagine that's a nightmare, but maybe there's a path forward. Maybe you guys are thinking about that. And then from a practical perspective, just navigating some of those issues seems like it's really going to be a big deal moving forward.
Well, it's great to see you again, Dr. Nayak. First of all, I didn't have a chance to say that. These are exactly the questions that we have. There's even the question of, like, let's say there's a really famous XYZ doctor in some town, in a different state. Will all patients just flock to that doctor who's got great online reviews? And so, do we continue to have networks, and are those networks geographically constrained? And, we have that now, but how much does that matter once you have telemedicine? Can we go over state lines? Could somebody from Vancouver, Washington go to Oregon Health Sciences University? Because that's really their closest one. So these are a lot of details that we still have to work out, and CMS will be making policy here. And again, I think that, groups like you should be opining on how to do this right.
I think it goes both ways as well. Us seeing the patients day to day and realizing what our pain points are and what the patient's perceptions are. We've done something called asynchronous visits in our clinic, where we use the MyChart patient portal to send patients sort of a visit questionnaire at a different time, and they fill it out and send it back to us. And we've actually reached out to patients to ask about their perception of doing this, and in general, very positive in the ability to kind of manage some of these conditions without having to come in. But also, interestingly, for certain conditions like stable coronary disease, the feedback from that group of patients was overwhelmingly, I want to come in every year and see my cardiologist. And so, Dr. Nayak and I have learned a lot over the last year or two about, how do you layer in virtual visits with your clinic visits? Is it by time period? Is it by disease state? Is it, what factors are involved? And so I think continuing to have a communication between us and members of Congress and saying, here's what we're seeing, and helping to advocate for us. I think that's where we need to continue going.
Maybe we make the rules kind of broad, right? Because we're trusting doctors to take good care of patients. Like, maybe we just trust the doctors to say, hey, this is a person I need to lay eyeballs on, and this is a person I don't. So, how much of this does Congress really need to trust or to touch, and how much of this has to be rules?
Yeah. Well, I wanted to talk, go ahead, Dr. Nayak.
No, I think that's exactly right, because, the way if you almost approach telemedicine like a tool, it's like your stethoscope, right? Like, sometimes like you really need to use your stethoscope, even though you have an echo and an EKG and all this other stuff. Like it's almost like treating it like any other tool in our armamentarium clinically. And you don't want to have to legislate that, because then you start to get into a lot of different kind of gray areas and even medico-legal areas. And I think that focusing on the clinical aspects of it, I think are huge. I think that's spot on.
And we all make those decisions every day. I mean, right? Like every day we see a patient and we say, I'd like to see you back in 2 weeks, or I'd like to see you back in 6 months. So how is this any different, right?
Yeah.
Right. Or this visit isn't cutting it. I've got to see you in person. We're going to need to convert it. Can you come in tomorrow?
Yeah.
Provider discretion, right?
I wanted to talk a little bit about, Joel, did you have a comment? I'm sorry.
Yeah, just a little bit of a comment. I think I use telemedicine as both Dr. Nayak and Katie know, quite a bit in my lipid clinic world. And I find actually, because a lot of what I do is lifestyle coaching, and I find it very effective, to once a month, tap into someone virtually to kind of be their accountability coach from their, compliance and their nutrition and their exercise. And so and both Katie and Dr. Nayak and I are looking at some apps and things like that will also help us. But also it's that connection with the individual patient, spouse, family, whatnot, that I see that allows us to improve that adherence, as Jen was talking about earlier with, compliance and medications and things like that. And so I personally, I've found it, even though, and whether it's audio or video, and Congressman Schreier, I think, that's a huge area from a reimbursement perspective, because I'll be honest, we sit in these meetings all the time getting drilled about, hey, we're getting paid for the phone, and we're getting paid this for the phone and this for the video. We got to do video. And that's, sometimes that's just the wrong answer, but it is what it is, the reality we are. However, I think that, particularly with obesity, diabetes, cardiovascular disease, et cetera, tobacco cessation, as Joelle knows so well in April, we can do a lot of this virtually, and we probably should actually, because it improves our access to the patient, our access to them, and their access to us. So I just wanted to kind of put that out there.
And so much of that can be done on the telephone. The coaching that I do as a certified tobacco treatment specialist and a nurse practitioner is often the behavioral counseling and the medication management. And it actually doesn't take an audio video. It's ideal if we're on video, but many of these people we know that 80% of people who have serious mental illness are dependent on tobacco. This represents a big portion of our population. So again, these are people who have a high no-show rate in clinics. But they will take your phone call, and we do have better outcomes when we have frequent opportunities to engage in behavioral health, motivational interviewing, and all the sort of opportunities to insert the techniques that we know that work. Plus, it feels weird to ask them come for 60, 90 miles away for a quick medication adjustment when they have to drive in crazy traffic, park at high financial rates, at least for us in the city. So it not only is pragmatic and sensible, it feels ethical.
So Joel touched on that a little bit as far as audio versus video, and some of the pressure that we feel. And I'll be the first to admit that understanding the difference in payment parity for video versus audio only is still confusing for me. And I feel like it varies based on state and based on insurance company. But maybe some of the panel can clear that up for me. I think we're feeling a little bit of pressure to prioritize video visits due to this real or perceived payment disparity. And just my question to the panel is should they be reimbursed differently, and why? We've talked a little bit about some of the benefits of audio only, and there's pros and cons to each. So I wanted to kind of touch on the issue of payment parity for audio versus video visits.
Correct me if I'm wrong, but the bill that I put through that covers the period of time that we're in the pandemic emergency has pay parity for video and audio. So right now, I don't think that's an issue. However, you can look at having different pay scales as sort of yet another way that mental health is downgraded, right? The things that you can do by phone, mental health, probably diabetes counseling, endocrinologists are one of the lowest paid specialties. I think it sort of reinforces that just the bias in payment models. And certainly until we have high-speed internet everywhere and everybody has access to the same technology, my opinion is that they should be reimbursed in the same way. Another little tricky area is that for better or for worse, I remember spending about an hour every day after work returning phone calls, and that was free. That was just my time, follow up, whatever it was. I don't know if it ends up that each one of those 5-minute phone calls then becomes a billed visit. I don't know if that's right or wrong or what that does to our medical expenses overall. But they also can be a way of keeping people from having to schlep into the office.
Yeah, I think
I'd like to give an example. a couple of years ago, I was working with these surgeons locally, and we had two men, 90-year-old twins that live out in Port Angeles. And one of them was having some obstructive symptoms, GI symptoms. He came in, had a workup with us, and it turned out that by histology, he had a stage 4 gastric cancer. And I had just launched the clinics, and we didn't have the same payment or the legislation to support our surgeon to see that patient back by telehealth. But these were these two men, these 90-year-old twins, only had each other in the world, and one was its ears, and the other guy was the eyes. They both had deficits, and they're driving on a 2-lane highway to get to us, and they're asked to come back in to have a conversation around stage 4 cancer that could have very easily been done over the phone. And I will say this, based on our current reimbursement models, the complexity of care and the time spent with the patient would have been exactly the same in that conversation, and he did not need to be in person. And yet we had to ask those people to get back in a car and endure the strain in January to drive all the way back into the city for a conversation that is painful. And so I use that as an example of, where telemedicine can be really helpful. And if we're going to continue these payment models based on complexity of care and time spent with patients, there is so much that we can do by audio, video, and by telephone to serve our patients well.
Yeah, it's kind of interesting how even at the beginning of the pandemic, we were kind of being told to do video visits, and I had a lot of patients where I was doing that, and then now here we are again, another kind of push towards virtual visits, and those same patients prefer to just use the phone. And so it's almost like you've got a case control trial going on right now with a lot of these people. And I think it's just kind of speaking to the fact that sometimes you got to see the patient and they want to see you. And sometimes a phone call is totally fine. And I think the payment parity issue, as Katie touched on, is really being pushed towards, kind of not necessarily doing it that way. It's patient, there's a lot of uncertainty. The codes are a bit different, and then people don't know, should we build this? Should we build that? And so thankfully we live in a state where they've been very proactive. I think Governor Inslee signed into law some degree of payment parity here locally as well with state regulated insurers earlier this year. And obviously, at the congressional level with CMS and other federally financed healthcare programs, with Congresswoman Schreier, we've been able to get some degree of payment parity. And I think that that's going to need to be sorted out as we start to get beyond COVID and start to think about everything we're learning right now with telemedicine and kind of making sure we're leveraging that going forward. Joelle's great example. I mean, that's a perfect example of why we need to ensure we're kind of codifying all of these learnings over the course of the next, 6 to 12 months, maybe less ideally, but hopefully we can start to get our hands around that a little bit.
And one of our issues is that there's too much inconsistency across federal and state laws and what, for example, payment parity applies to private payers, Medicaid at the state level, et cetera. Coming from the top down, it sure would be helpful to just have a unified language that applies to all so that we can all just kind of get on the same page and get compliant. And like you alluded to, Representative Schreier, let the local licensing regulatory boards determine based on their discipline that they oversee how they're going to manage quality outcomes measures with their providers, et cetera. And so that we can just start ironing this out and making a path forward.
There's a comment here from the audience, and I think this is something that Dr. Nayak and Joel and I have noticed in our clinic specifically, and I think it's a commonality among probably everybody over the last year or two, that initially, probably April of 2020, patients were very excited about telemedicine because COVID was what we thought was the peak pandemic. They didn't want to come in, and they were very excited about the opportunity to talk with us virtually. And then we kind of saw the pendulum swing in the other direction, and we had kind of an influx of patients who really did not want to do virtual visits, and they wanted to come back and see us. And part of that, I think, was social isolation. A lot of our elderly patients had been essentially on lockdown in their facilities and not interacting with people, and they really valued that ability to come into clinic and see us face to face. And so I think we're swinging back a little bit in the other direction, but how do we incorporate this now in our long-term strategy? How do we incentivize telemedicine for our organizations? Because it does require a greater vision to incorporate that into how we deliver care, and how do we incentivize it for patients? Because there are a group of patients now who maybe are less enthused about it than they were 2 years ago.
I don't know if I'm the best person to answer this because I'm not practicing telemedicine right now, but I do know that with my doctor and with my parents' doctors, there are certain days when they're in the office and there's certain days when they're just functioning virtually. And so scheduling alone may shape what the practice looks like. If you can't see your doctor in person for 3 weeks, but you can have a virtual visit tomorrow, that will shape what people do.
I think that, kind of thinking upstream in terms of how what our managed care models look like, what our care delivery models look like are also really important. So, it's interesting because we have this value-based purchasing model where we've got payers who have patients who are in their managed care organizations. We are, as healthcare providers, under sort of these health systems responsible for meaningful care delivery that demonstrates high quality care for less money, right? So that really should be team-based. That should be multidisciplinary. And we understand that at a local level, but we're not rewarded for that. And we don't have policies in place that facilitate that. And we have a very, again, disparate payment models and varying incentives for creating, developing a well population versus a sick population that continues to incentivize hospitals to have people coming back in the door. And I think most people know kind of where I'm going with this, so I'll just stop right there. We need to build care delivery models that are right for our patients, that do the right thing first and foremost, and build policy that it really aligns with our goals at a really high level, all the way down to the patient, so that we have the resources that we need to do the right thing for our patients, and we're rewarded based on that. And we don't have time to go into the nuts and bolts of that, but some of it does have to do with how insurers are paying. I also think that insurers can do more, including getting devices to their patients. I think it can't all be on health systems. I think that we need models of care that include all stakeholders, and that includes insurers, payers.
It's interesting. I think you're exactly right. And it's also interesting how, some patients really, if they're having an issue in cardiology, it could change. Like I could say I need to see them in 6 months, but and I can see them virtually because they're so straightforward, but on day 5 month 29, they have chest pain and I need to see them in person and I can't do a video visit with them. And so the scheduling part of it, I think is actually, I've kind of tried to make this point with our EMR scheduling folks, is like, if you can figure out how I can, modify my visits to virtual if they're stable and they don't need to come in, versus if they're not if they're having an issue and I need to see them and the patient can control that, that would be a total game changer, especially if you can control it literally at the point of care, and I think that all of these issues, if you just put the patient in the center and you just try to figure out what's best for them at the time they need the care, you'll solve so much of these issues. Because I think as most of the providers will do the right thing for the patient, they're not so much worried about some of the billing issues and the technology, which is going to change. We're going to be doing things in a couple of years anyway. So I think these are all amazing points that everybody's bringing up. I've learned a lot.
And I will say there is some beautiful technology out there, and I try hard to stay away from brand names, but I will tell you that I have interacted with a company that has this kit that is great for heart failure patients. So Dr. Nyack and Dr. Bates discharged a patient from the hospital with a new onset heart failure. You can have a relationship with this company. They'll dispatch this kit that has an O2 sat monitor, a scale, a tablet, a blood pressure cuff, and it's everything that they need set up, right? So we need payment models. We need payers that are willing to reimburse for that equipment. It shouldn't be on the provider. It shouldn't be on the patient. The patient can set that up, and there can be personalized videos by Dr. Nyack and Bates that are triggered if the patient's weight is up by a kilo. And it can be, what was your sodium intake like? You can even dial the provider's office at any time by pushing a button on the tablet. Like, these things help, but we need payment models that support reimbursement for asynchronous monitoring, remote monitoring, and data, download and review of that data, right? Someone needs to look at it and someone needs to be monitoring it. So it's like, the innovation is there, but we have to connect all the dots and figure out what that looks like. But again, it has to be that collaborative model and that shared expense, and that accompanies that shared interest in doing the right thing and figuring out how to really kind of leverage this equipment and also get that data to communicate with our EHRs. Like, it's so exciting, and yet we're struggling to get all of these things in alignment. But there are ways that we can do it. I'm sure of it.
Yeah, I think you hit the nail on the head. That I think a theme that has come up in our discussion a few times is the technical support for telemedicine. We talk about in our own practice with our asynchronous visits and in telemedicine, we talk about the issue of having dedicated IT support and somebody available at a moment's notice to help us work through the challenges of our video visit that doesn't connect, and who monitors all of these remote patient monitoring data, and how do we integrate whether a patient is even appropriate for telemedicine into the EMR? How do we designate this is a good telemedicine patient so the next person down the line can say, yes, I can schedule a visit with this person via phone because they're appropriate, they're not hard of hearing or other things like that. So that's something I think we're going to continue to face challenges with, but also there's a lot of exciting things happening as far as some of the things you mentioned with the devices and these kits and some of these companies that are coming out with these resources. It's about 12:14, so I just wanted to be mindful of everyone's time and just open it up to any other final comments. It's really been a great discussion. I think we could probably talk for another hour or two or more about telemedicine and just care delivery in general. So first off, I want to thank everyone, Congresswoman Shire, for taking your Saturday to chat with us, and Joelle and the rest of the panel. But if there's any other final thoughts from anybody, I'd like to open the floor.
I just want to chime in a couple of maybe thoughts, because my practice is split between Harborview Medical Center and UW. And so uptake of these telehealth resources is very disparate depending on which site I'm at on which day. So at Harborview, it's nearly impossible, not completely impossible. I do have a few patients that can, that have the resources to be able to complete telehealth visits, but it's like extraordinarily different from my UW patient panel. So I think, you know, a lot of these technologies are, will be helpful, but there are just some basic issues like unstable housing and with that theft of personal property that happens much higher in some of these patient populations than some of the other ones. So I found this very interesting. I think some of the challenges are also disparate according to people's resources as well.
That's a great point. We think about rural barriers and the fact that we are taking care of patients that are 200 miles away from us, and here you have patients that live in the same city, albeit a very big city, with these differences, and it's kind of fascinating to hear about. I actually never even thought about the issue with theft of personal property, so that's really interesting that you bring that up.
Yeah, we have I'm just to plug some of the Harborview providers. Many of the clinics have in-house pharmacists and nursing teams that hold on to meds for patients, and then have patients come in weekly or bi-weekly or bi-monthly to come in and get their Medisets filled, so that they're never missing too many of their meds in case things get stolen or lost. Wow,
that's great. Any other final comments from anyone else before we wrap up today?
You know, I'd just like to thank you, Katie, for putting this together. Just an amazing job. This whole meeting has been terrific, and really appreciate all the work you did to put this together. Liana, I see your little avatar there. Thank you for all of the great work that you've done as well in getting this meeting together. And thanks again to all the panelists and everybody that spoke. And I will say that I think we need to notify National ACC, because we got a member of Congress to actually say JVD in a discussion. I don't think I've ever heard that. And I watch a lot of the news. So I feel like I'm very proud of our representative from Chelan County here, who has done us all very, very proud in all the work that she's doing. Thank you, Congresswoman Schreier, for everything you're doing for the medical community and the rural communities here in North Central Washington specifically.
Well, thank you. And thank you for having me. I'll see what other acronyms I can pull out next time we meet. and I should note, we were just at Snoqualmie Valley Hospital, and we saw a robot telemedicine arrangement where the doctor locally could put a stethoscope on a patient and it transmitted the sound to the doctor. I mean, they couldn't do it from home, at least not yet, but maybe those stethoscopes can be rented out. I mean, you never know. You know, we developed telemedicine and technology will follow. So exciting times. Thank you all.
Thank you.
Thank you.
Well, that concludes our symposium for today. Again, thank you to all the speakers and panelists and all of our guests in attendance. I hope you guys learned something new today. There will be some email notifications coming out in the next week or so about continuing education credits, and this event will be available for playback on the ACC website at a later date as well. So if you have any other questions, please don't hesitate to reach out via email. And I hope to meet some of you in person someday soon. So have a wonderful rest of your weekend. Bye-bye.